Наш мир не стоит на месте. Он стремительно развивается и дополняется новыми данными. За 5 лет человечество произвело информации больше, чем за всю предшествующую историю. Прямо сейчас мы становимся свидетелями развития компьютерных технологий, освоения космоса и инновационных открытий в медицине. Современный образовательный процесс требует от специалистов постоянного совершенствования, в том числе и в вопросах научно-практической квалификации. Возникает острая необходимость в независимой площадке, позволяющей специалистам иметь доступ к передовым достижениям в области терапии. Евразийская ассоциация терапевтов – это уникальный глобальный проект объединения специалистов разных стран и различных областей клиники внутренних болезней, направленный на развитие и совершенствование помощи пациентам терапевтического профиля. Это современная площадка, предоставляющая участникам Евразийского медицинского сообщества доступ к уникальной базе данных, а также возможность обмениваться мнениями и делиться опытом.
Мы объединились здесь, чтобы сложить наши усилия в борьбе за долголетие, процветание народов наших стран.
В Ташкенте открылся 4-й съезд Евразийской ассоциации терапевтов.
В Минске открылся 5-й съезд Евразийской ассоциации терапевтов.
И мы всегда с оптимизмом смотрели в будущее. Нас объединяют общие корни, общая история. И я надеюсь, нас объединяет светлое, большое будущее.
Миссия ассоциации – создание международных медицинских, исследовательских и образовательных проектов между странами Европы, Азии и СНГ. Ассоциация проводит образовательные мероприятия с участием ведущих экспертов. Съезды, конференции, телемосты, школы. Научная программа конференций подготовлена с использованием современных образовательных методик и инновационных форматов. Сегодня ассоциация уже объединяет тысячи практикующих врачей и экспертов из России, Европы, Азии и СНГ. Она помогает совершенствовать медицинские знания и опыт каждый день. Для нас важно сделать процесс медицинского образования непрерывным, современным и максимально доступным. Вступив в ассоциацию, вы становитесь частью глобального сообщества специалистов, работающих под научной и практической составляющей современной терапии.
Итак, добрый день, уважаемые коллеги. Позвольте открыть второй день работы 10-го.
Good morning, distinguished colleagues. Let us start day 2 of the International Conference of Eurasian Association of Therapists. We launch our session in St. Petersburg Hall. This is one of 3 segments of Congress which is carried out online. And today, I hope we are having a very interesting agenda. This is what we are expecting today. And in fact, it is broadcasted directly from St. Petersburg. And this is exactly the part of the Congress that would be devoted to the issues of hypolipidemic treatment and to the aspects of arterial and venous thrombosis management, their complications and optimization of their treatment, and definitely the other issues which cover gastroenterology, challenges in comorbid cardiology patients. At the same time, we are expecting 12 speakers, top-level experts, global experts that will present the most interesting innovative approaches for the diagnosis and treatment. And let me launch our day 2 of work online Congress with the symposia that is devoted to the new horizons of hypolipidemic treatments. And it's my greatest pleasure to introduce our first speaker, Viktor Gurevich, who is a professor, doctor of medical science, the lead of atherosclerosis treatment center, lead of the atherosclerosis chair in the Clinical and Educational Cardiology Center from St. Petersburg Medical State University. And the topic of his presentation, updates in the National Atherosclerotic Society, guidelines, correction of hyperglyceridemia, and the focus on the reduction of residual risk. Are you with us, Professor Gurevich? Yes, we can hear you and we can see you. Very positive. That's great. So, Professor Gurevich, once again, we are happy to welcome you, and the microphone is yours. Thank you very much. Good morning, distinguished colleagues. Today, our task is to introduce you some new trends in the diagnosis and in the treatment of atherogenic dyslipidemias. And let me start from so-called residual risk. The definition of residual risk was given in multiple complications. So this is a risk of cardiovascular events that is still available, although the patient is already in target for HDL, for BP, glycemia, according to the current standards of treatment. In fact, the contribution into residual cardiovascular risk is made by a number of serious factors, starting from the out-of-target healthy lifestyle, which is not reached, that can be corrected by non-medical activities, but the most important is out-of-range HDL level, inflammation, and today I specifically focus on hypertriglyceridemia. Please appreciate, these are risks related to atherogenic dyslipidemia. If we take such factors like anti-atherogenic cholesterol, HDL, LDL, for example, and triglycerides, they can characterize the changes of cardiovascular risk the following way. If TG level is increased from the normal range up to increased range, and with the reduced level of alpha cholesterol, which is HDL cholesterol, from normal range to very low range, then the risks versus reference units will be increased by many times, would be doubled, quadrupled, and in case of high level of TGs and low alpha, sometimes risk is 10 times higher. This is a very important position because, in fact, it is directly linked with so-called mixed dyslipidemias. Mixed dyslipidemias, we used to call them combined hyperlipidemias. They are defined like increase of LDL and TG that very frequently associated with very low level of alpha, HDL level. Probably you saw it many times, and it has already been proved statistically that vast majority of the patients after acute cardiovascular coronary events could be characterized by specifically this type of dyslipidemia. Let's appreciate the following. This is a link between the level of TG and the risk of coronary artery disease. This is direct link from TG and opposite, reversed from anti-atherogenic lipoproteins of high density, HDL, high density lipoproteins. Familial and secondary mixed hyperlipidemia and dyslipidemia are quite prevalent both in Russia and all over the world. Up to 40% of adult population do possess this type of dyslipidemia, so-called mixed dyslipidemia. If there is an established cardiovascular disease, as you can appreciate it here, so it's up to 55% can have mixed type of dyslipidemia. Diabetics, more than 60% of prevalence, and definitely patients with metabolic syndrome, almost all of them, 100% do have this type of mixed dyslipidemia. Here you can appreciate classification of hypertriglyceridemia, because this is a very important metabolic contributor in this type of dyslipidemia. Is a bit different between cardiologists, and it's shown here, and endocrinologists and GPs, which is shown on the right. So the normal levels are less than 1.7 millimole per liter in both professional associations. The borderline up to 2.3, that means 2.2, 2.3, but everything which is higher than 2.2, 2.3, then cardiologists consider the risk as a high risk, starting from 2.3 up to 5.6. Although the risks of pancreatitis, chronic or acute pancreatitis, they're mainly concentrating with the levels of up to 11, up to 11. That is why, let's say, endocrinologists were more relaxed to these figures. But for us, for cardiological community, I emphasize it once again, the risk starts from the level of 2.2 millimole per liter. This is the threshold for TG, 2.2. What are the reasons? What are the main reasons? Let me speak up briefly. So primary, which is familial hypertriglyceridemia, combined hyperlipidemia, DISBEL, and familial hyperchylomicronemia. Also, there is secondary related to diabetic or nephrogenic dyslipidemia, metabolic, postmenopausal, thyroidogenic, alimentary, drug-related hypertriglyceridemia. All that is available. If you see TG level higher than 10 millimole per liter, please think about the combination of both genetic and secondary factors. Fenofibrate, Tricor, as we know, slows down the development of major manifestations of cardiovascular manifestations in patients by 20-25%. And it has recently been confirmed by particular studies, for example, ReviewSit and Field, retinopathy, albuminuria, non-traumatic amputations. All this is dramatically, statistically significant, reduces by the effect of fenofibrate with the long-term continuous treatment. Fenofibrate actually taking a very special position among other well-established treatments of the first and the second generation. You can appreciate it here. First, fenofibrate reduces the level of LDL as well as statins, but a bit lower. Very seriously, up to 50%, reduces the level of TG and increases the level of anti-atherogenic alpha cholesterol. We know that combined treatment, Tricor plus any statin, well, effective one, for example, rosuvastatin, allows dramatically more frequently, almost twice more frequently, reach target levels of lipids that we're going to talk about today. Please appreciate this difference. This is a combination, and this is monotherapy of statins. So definitely, combination is much more preferable. Combination of fenofibrate plus statin does not cause any doubts anymore. And moreover, this treatment is very well tolerated, and here you can appreciate the ACCORD study, lipid part. So it introduced a dramatic improvement into the understanding that this combination of statin fenofibrate is not simply effective, but also quite safe, as you can appreciate it here. So the difference between placebo and the drugs, we can see how it's changing creatine phosphor kinase, CPC, and other muscular parameters. So as the algorithm, a medical algorithm of triglyceridemia is presented here. If this is within 5 millimole per liter, then the first question we are asking is the statin treatment is indicated or not. If yes, if it's indicated, then after 8 weeks of treatment, we are waiting for the change of TG level. If TG level is higher, 2.3 millimole per liter, then surely we add on fenofibrate and we can add on omega-3 fatty acids, Omacor. If not, we just continue treatment with statins, and the rest is very simple. TG higher than 5 in the absence of cardiovascular risks, and then first is fenofibrate, which is Tricor in Russia. In severe cases, plasmapheresis, apheresis of lipids, and if it's up to 2.2, then we consider non-medical treatment. But if you see normal level of triglycerides, this is 1.5 to 1.7. That's actually it what I wanted to share with you today from the very beginning for our future discussion. Thank you very much for your attention. Thank you very much, Victor. Thank you very much. Yes, very comprehensive, a very clear presentation. You can appreciate that residual risk here is one of the most important and discussive issues because of the management and the control of LDL is not sufficiently influential for cardiovascular outcomes. So there is our area of therapeutical interventions that we need to take, we need to manage. And you're absolutely right, Victor, saying us that we need to keep in mind not only just the algorithm, not just the general approaches for the management of the Europe, but just commented it through the aspects of discussing of pharmacotherapy. Well, distinguished colleagues, and now we are happy to give the floor to our next speaker, and this is Alexey Panov, Professor, Doctor of Medical Science, and the lead of the Scientific and Clinical Department of Ischemic Heart Disease Medical Center named after Almazov. And his presentation here is atherogenic dyslipidemia and high cardiovascular risk. Alexey, can you hear us? Yes, I can hear you very properly. Can you hear me? Yes, yes, we can hear you, absolutely. Well, thank you very much, and the floor is yours. Well, first of all, I would like to express gratitude to the organizers. And my presentation today is a logical continuation of previous presentation by Professor Gurevich. And this is the position of Almazov Center on the issues of atherogenic dyslipidemia and high cardiovascular risks. Professor Gurevich already noted it like mixed dyslipidemia, and you see there are multiple names here. And somehow I cannot move my slides. So there are multiple names. Thank you very much. So as you know, heterogenic dyslipidemia is presented very differently, and it's called very differently. Mixed dyslipidemia, heterogenic dyslipidemia. But if we take particular retrospective analysis, so back in 1999, in the journal Circulation, there was very first publication where they spoke about phenotype B dyslipidemia. That's exactly the combination of what we are discussing now, which is high level of TG. So normally, not very high level of LDL and reduced level of HDL, anti-atherogenic lipoproteins, high-density lipoproteins. So we do apologize, and currently we cannot manage this problem. Let's do it the following way. I will take the attention of the audience, so please try to contact our technicians. Our technicians will contact you in a minute. And let me mention one important issue which was missed before. It is related to the fact that at the end of our symposium, which is ongoing now, symposium which is devoted to the new horizons of hypolipidemic treatment, we are expecting Q&A session, and you are invited to participate in their discussion. You will know the position, so you will know everything. And in the format of our Congress, we are expecting the list of issues, and please provide your questions, comments, remarks. So all those who are with us today, all those who are interested in the topic of atherogenic dyslipidemia, if you want to ask a question, so please no hesitation. Please refer to our website, and please address your question properly to one of the speakers or to all the speakers. So that would be really a very good solution. Also, let me remind you that today we are expecting the presentation of Dr. Abrizan, who is the representative of a very big university, Moscow State University. This is chair of hospital treatments. And also we are expecting presentation of Professor Konstantinov, who is also share his position and his view, who is the representative of another school. He will present his view on the aspects related to the nuances of dyslipidemia management. And I do hope that we will keep timing regardless all technical issues that we are facing currently. So I think everything works perfectly. And please, Professor Panov, the floor is back to you. Well, thank you very much. Well, a little bit of the story. This is the circulation. That is the publication I talked about before, where the data about the association of this particular phenotype was presented. This new word, ALP phenotype B, and increased risk of cardiovascular diseases. Speaking about the prevalence, well, we always start from prevalence. So this is a very famous DICE study where the investigators included more than 20,000 patients. It was carried out in Europe, in Canada. Russian Federation was also included. You can appreciate here that those patients who were receiving statins, so this is how frequently we see hypertriglyceridemia and the lower level of HDL, so up to 40%, especially if we look at patients with metabolic syndrome, with diabetes. So most frequently we see this. And Professor Gurevich already showed this slide, and if we appreciate different quintiles of triglyceridemia, so the higher is the TG level and the lower is the level of HDL, the higher could be the cumulative risk of the patient, risk of cardiovascular disease and cardiovascular catastrophe. What are the potential mechanisms? Here they are. The mechanisms are really multiple. You can see TG-enriched lipoproteins. Sometimes they're called ugly sister, So some European experts call it ugly sister of cholesterol, which is contained in LDL. So in a few words, speaking about the pathogenesis, most frequently the reason is definitely hyperproduction of TG by liver. It is associated with increased lipolysis, and this is what we frequently see in case of insulin resistance. So in this situation, in hyperproduction of TG, we see a lot of huge, very low LDL. And then two mechanisms possibly can be initiated. So here you see triglyceride-rich lipoprotein cholesterol. Then you see large VLDL. And by the way, manage them HDL, and they become very small. They become very small, these remnants. And so this very high density HDL, small HDL. And on the other hand, we see increase of LDL, so and they become more atherogenic. So we know the president of Portuguese Society of Atherosclerosis, Professor Aguar, he presented these events like buses, what happens in this very special rate of dyslipidemia. So on top, it's a normal situation when we have normal level of TG and the VLDL, very low density lipoproteins, and they cannot enter. They cannot enter through the artery wall, and they cannot introduce excessive cholesterol there. What actually enters is low density lipoproteins, LDL, but we have brilliant mechanism here. It's statin. But in the situation of hypertriglyceridemia, we have pretty many remnants of VLDL, which are enriched by TG, and they're not very large. So they can successfully permeate, so they're permeable, so they can get in through the artery walls, and this is how they introduce additional cholesterol into the vessels. So it appears to be that and in this situation of hypertriglyceridemia, This situation is definitely associated with the process, attraction of inflammatory cells. And in this situation, when you see the situation of LDL, you see that finally we have malignant cores. So what do we have available? Speaking about the guiding documents, and first of all, these are the guidelines of European Society of Cardiology dated from 2019. If we appreciate this data produced by ESC, we see that TG by itself is not a target. Is not a target there, but with a level less than 1.7, we know that this is low risk. So this is a low risk of cardiovascular event. If there is increased level, we have to pay attention to other risk factors, and this is exactly what we do. Why this not very active attitude to this issue, why it's not in the big focus, why it's not considered separately? Because if you look at the studies of fibroids, because fibroids today are the most effective treatments, speaking about increased level of TG. This is Helsinki study. This is primary prevention. So everything was really great for cardiovascular outcomes, but we clearly saw the positive effect in diabetic patients. And then further studies definitely were carried out in patients using fibrates, in patients with diabetes. But very modest results were received by the patients that were included here. They had normal level of TG. This is filled, accord, and accordion. But if we select the population in this group, in the preserved dyslipidemia, then definitely you see 1/3 reduction of MACE, major adverse cardiovascular events related to the coronary artery disease. And this is the key issue for today. I think it is this study that gives us new view on the challenge, and these are the results of Reduce IT. Let me remind you the design of the study. This study recruited patients with established cardiovascular disease, patients of very high risk, and almost 70% of patients had established cardiovascular disease. And the second category are patients with diabetes who had at least one additional risk factor. So patients were receiving statins, and in this situation, the inclusion criteria was the preservation of TG level higher than 2.3. And here, you can easily appreciate it. So these patients were randomized in between placebo group and very big dose of omega-3 PUFAs, polyunsaturated fatty acids, was used to reduce this TG, and we saw it with statins. So, and we haven't seen such results. You see extraordinary statistical significance, p-value. Primary endpoint here was combined. It's included cardiovascular mortality, myocardial infarction, stroke, revascularization, or heart failure hospitalization. So you see unstable engine is also part of it. So absolute risk, 4.7%. Yes, we very rarely see such results. So from this point, I think it's high time to have new interpretation of the guidelines, which are currently available. So here you can appreciate the following. So again, if we talk about the documents of European Society of Cardiology shown here. So we can say that there is a liberalization of using omega-3 polyunsaturated fatty acids and fibrates. Definitely first class of evidence in the situation of increased level of TG and the administration of statins. Then in a high risk, even 1.5. So regardless of the statin treatment, so it is recommended at the level of 2A. This is very strong level of evidence. And speaking about the drug, there is only one, which is Omacor and Tricor. So primary prevention, more than 2.3, and also we don't see any indications to a very high or super high risk in the primary prevention. So level of 2B, we can consider the treatment of fibrates in patients of high risk. So fibrate can be considered in combination with statins. And Viktor Savelevich already spoke about the fibrate, and we have the only drug registered, which is fenofibrate. This is activation of PPR alpha receptors. So this is very targeted effect to the situation of atherogenic dyslipidemia that we are discussing today. So this is increased level of HDL. This is active split of a reduction of TG level, a reduction and low lipoproteins of low density in the vascular wall. And speaking about the specific drug, fenofibrate, we speak a lot. We speak a lot about nanotechnologies, pharmacology, etc. So this is very bright example, Triker. Triker actually was created using this very fashionable nanotechnologies. And from here, we see the specificity of pharmacokinetics. So this is option to use minimal doses, 145 milligram maximum bioavailability. And finally, we get effect related to the activity with a dose of drug and minimal rate of adverse events. So summing up, cholesterol definitely today has a fundamental role in the development of cardiovascular diseases. But in many patients, the only cholesterol which is responsible for the disease is definitely cholesterol, which is in LDL. But as we saw it from the very beginning, the development of atherosclerotic cardiovascular diseases definitely included cholesterol, which is carried out by TG and rich lipoproteins. Statins is a first line of treatment, and if we know that they are influencing lower to the very low density lipoproteins, if TG is still high, then regardless the treatment of statins done today, we are having the option either the combined treatment including omega-3 PUFAs and fibrates, and definitely this is fenofibrate, speaking about the combined treatment. So today it is actually the only one which can be safely combined with any statin, and definitely good statin if we speak about hypolipidemic treatment. So thank you very much for your attention, and hope I'm meeting the time which was given to me. Thank you very much. Thank you very much, Alexei. Yes, you are extremely precise. We are sticking to timing, and this is very good. Thank you very much for your very interesting report. That was one of the best representation of pathogenetic specificity of dyslipidemia. And although we have very convincing data on reduced IT, and again, we are still see that hypertriglyceridemia is a very serious and a very respected agent that should become the target and very important objective for our interventions. And distinguished colleagues, now I'm happy to give the floor to our next speaker, and this is Andrei Abrazan, who is a professor and doctor of medical science and the lead of hospital treatment chair of St. Petersburg University. And he will make probably one of most controversial presentations today in our current discussions in the current lipidology and cardiology. This is a topic of using omega-3 PUFAs, polyunsaturated fatty acids. And I believe it is currently discussed by everyone, from pop stars in Instagram up to the experts of the highest level. And it is exactly Professor Obrizan who will put all the dots over the I's and who will show his interpretation, his understanding, and his attitude to the efficacy of this approach. Distinguished Vladimir, distinguished colleagues, well, I hope you can hear and see me properly. If something is wrong, please let me know. And you are absolutely right, Vladimir. You presented very brightly the challenging of issues, polyunsaturated fatty acids, introduction of omega-3 into the clinical practice. It was like, was a march. It was a cavalry march because GC Prevenzione showed brilliant results for the reduction of mortality, cardiovascular mortality, strokes, and myocardial infarctions at a very, very low levels. Also, GC Prevenzione showed that Omacor reduces mortality from HDS, ischemic heart disease, and sudden death by 53%, and everything was really fine. But contraindications popped up, and that was the reason to ask additional questions into the RCT guidelines. Amistami 2012 position was counter argument for omega-3 PUFAs, and particular analysis concluded that it did not allow them to recommend omega-3 in routine practice for patients with MI in history. The same happened to guidelines of 2012 for acute and chronic HF. So omega-3 unsaturated PUFAs after myocardial infarction is uncertain. So they did not see particular benefits, and probably statistical analysis limited to the limitation. But at the same time, in the same guidelines, they still mentioned omega-3 polyunsaturated fatty acids as upstream treatment of atrial fibrillation. At the same time, there were many questions, and when then we have to put omega-3 fatty acids to BB, class of evidence and level of evidence for the treatment of triglyceridemia and increase of TG, and at the same time there were questions about guidelines on myocardial revascularization, where omega-3 together with fibrates, level of evidence 2AB was recommended in combination with statins or isolated to the patients with intolerance of statins. What about ventricular arrhythmias? They were reduced, and this is class 2BB, and the most important reduction of sudden cardiac death. And it was so clear that our national document on the prevention of sudden cardiac death still included the useless of omega-3, the usefulness of omega-3 with in patients with ventricular arrhythmias. So this contrast, this against this is strength study which was prematurely stopped, and Cochrane analysis that almost showed nothing, but still it was quite controversial because it is even in the Ascent study. Please appreciate 15,000 population of UK, 1 gram a day omega-3, 5 years of follow-up showed almost no difference with placebo. There is no clear improvement of the primary endpoints, which is mortality, MI, or stroke. But in the same study, somehow they forgot about the vascular effects that were statistically significantly improved in those patients who were taking the same regimen of omega-3 PUFAs, which is Omacor. And again, now we have PRO, and this is meta-analysis of Mayo Clinic of 2019 and 2020, then meta-analysis omega-3 and cardiovascular diseases, American Heart Association, a reduction of myocardial infarction by 9% and mortality risk by 17%. So everybody started rethinking what is truth and what is still questionable. And then pathogenetical justification is definitely confirming the effect of omega-3. It restores the structure, has hemodynamic effect, increasing ejection fraction and contractility myocardial fraction. And also we have biochemical justification. So very clear and absolutely positive effects of omega-3 fatty acids to the metabolism of TG, reduction of liver secretion of lipoproteins, degradation of ApoP, suppression of CP-BAP activity. So there is very good evidence base. Now we have pharmacodynamic justification. We see that different levels of TG with different effects of doses of omega-3 acids would influence differently triglycerides. It could be 61% reduction and 20% reduction. So that means we cannot mix different protocols from the term of analysis and making final conclusions. So I wonder what is biophysical justification. So beyond that, first we need to say that in severe hypertriglyceridemia, Omacor omega-3 reduces TGs very effectively, a bit lower with simply moderate increase of TG. But the most important is shown here. Please appreciate these dark columns on the top. This is increase of low-density lipids with omega-3 acids. But this increase, which is negatively for prognosis, does not refer to the ethers of eicosapentaenic and docosahexaenic acid, and also doesn't refer to the ethers of TG with omicron effect. That's why TG ethers, should be administered in order to reduce TG and B, not increase low-density lipid. Then clinical and physiological justification. Just two examples, dear colleagues, two examples. Please appreciate omega-3, Omacor, reduces end-systolic size and increases ejection fraction. That means there is positive influence. Omega-3, Omacor, in patients with particular baseline treatment, beta blockers and amiodarone, reduces ventricular rhythm and the number of extrasystoles reduced by 20%. And these are high-grade extrasystoles. Omega-3 effect, not only TG reducing, but also antiarrhythmic, CHF correcting, so pleiotropic anti-aggregant effect, pleiotropic antihypertensive effect, very convenient effect of TG reduction and increased functional status of myocardium. So we see this really pleiotropic component. And there are multiple grounds against, and previous speakers, Professor Gurevich, Professor Panov already spoke about these multiple trials that in principle, if we analyze this line of option, do have positive trends on the prevention of myocardial infarction. And if we have a study reduced it 4 grams of icosapent, then it reaches statistical significance on the positive effects of omega-3 in different doses, in different years, in different randomized clinical trials about the prevention of myocardial infarction. And the same refers to the prevention of cardiovascular events. Maybe not all the studies, except JALIS, demonstrated significant benefit. Trend was not obvious, but as soon as we see reduce it, which seriously changed positive trends in favor of omega-3, icosapent 4 gram, and everything is improving. So currently, Omacor, omega-3 polyunsaturated fatty acids up to 4 grams a day can be administered in TG higher than Phe, higher than 1.5. So this is the area where, regardless the statin treatment, we still need to use omega-3 polyunsaturated fatty acids and possibly fibrates as well. RCT and meta-analysis of 2020 gives us very serious food for thought. Please appreciate here, reduced study, the analysis in subgroups. So all subgroups here, males and females, elderly and younger, with compromised and not compromised myocardial function, with and without diabetes, all of them getting benefits in terms of revascularization, fatal and non-fatal strokes and MIs. And these patients were taking icosapent, ethyl ester. And this is Mayo Clinic 2020. Very interesting. Please appreciate very much reduction of cardiovascular events, myocardial infarction, fatal events from 29% up to 41%. Yes, possibly totally coronary mortality just for 2%, but this is very important contributor. And speaking about MI, especially fatal MI, please appreciate 14 studies, 78,000 of patients, and this is more than a clear benefit of omega-3 polyunsaturated fatty acids. This is Mayo Clinic 2020, and this is dose-dependent effect. Please appreciate the higher is the dose of EPA and DHA, the lower is the mortality. So higher dose, fewer MIs. So cardiovascular events, morbidity, mortality, everything depends on A, what sort of omega-3 polyunsaturated fatty acid we administer, and then it depends on what is the dose of this omega-3 polyunsaturated. So summing up, distinguished colleagues, I have to say that all these contrasts that we just discussed in terms of disputable issues for omega-3, like data of strength or additional meta-analysis, Cochrane meta-analysis, they are losing those those in favor of, which we see in ASCENT, RCT ASCENT, which actually put all dots over aspirin and over omega-3, but still some analysis showing that not everything is so simple. And I'm pretty sure that in the near future, these results, this interpretation of the results will be changed, and we'll make additional conclusion on diabetes, on general population, on possible benefit of omega-3 pulfurs for some groups of patients for specific events, mainly vascular events, and mainly omega-3 ethers approved by FDA to reduce the risks of cardiovascular events. FDA is not an easy player. They never allow doubtful players on the market. So American Heart Association recommends omega-3 for the treatment of dyslipidemia, hypertriglyceridemia, and here or there we necessarily see how frequently omega-3 can be administered in hypertriglyceridemia, not only fibrates, but also omega-3, and then relevant meta-analysis 2019-2020, including reduced study in omega-3. They proved that the use of omega-3 associated with reduced risk of MI, cardiovascular mortality, and what we need to select is correct omega ethyl ester Almacor, correct dose from 1 to 4 grams, depending on what situation we are going to prevent. And finally, very correct group of patients where we would like to reach positive effects. Distinguished colleagues, dear Vladimir, dear audience, dear doctors, this presentation is completed and I'm ready to answer your questions, comments, and remarks. Thank you very much for your attention. Thank you very much, Professor Abrizan. So very complete, very interesting, and very comprehensive analysis of all these effects of omega-3 polyunsaturated fatty acids for the cardiovascular system, for different cardiovascular outcomes. Yes, thank you very much for this systemic approach. And now I would like to remind you that the Q&A session is expected after all the presentations. So I'm asking the experts to stay here and don't leave our session in Zoom because the questions are coming. The questions, comments, remarks are coming. And I would like to remind again all our audience, the distinguished colleagues, please provide your questions, comments, remarks to our experts in the web chat. And now let me give the floor to Konstantin, Professor Konstantinov, Professor Doctor of Medical Science, the Professor of Hospital Treatment Chair and Cardiology of the Northwest State Medical University, named after Mechnikov, with his presentation, Non-LDL cholesterol, who, when, and how measure? What is the diagnostic value of non-LDL cholesterol? Can you hear me? Yes, we can hear you and we can see you. The floor is yours. Well, thank you very much, distinguished colleagues. Today, I would like to talk about very well-known, but to a certain extent forgotten issue on non-LDL cholesterol. First, let me refer your attention to Russian guidelines on the diagnosis and correction of dyslipidemias to prevent and treat atherosclerosis 2020. So this is the first volume of this year, and these are new Russian guidelines for the diagnosis and correction of lipid disorder in order to prevent and treat atherosclerosis. So why? And actually, what for do we need this update? Because actually, the previous version 6 of the specific Russian guidelines, was accepted quite recently, just in 2017. So, but for these 2 or even 3 years, we observed multiple changes. And specifically, we faced new approaches to the treatment of dyslipidemia, including the use of monoclonal antibodies, PCSK9, and also new approaches to treatment in different categories of patients, in patients with diabetes, with familial hypercholesterolemia, in elderly, in females, etc. So at this slide, I summed up most important positions of new guidelines. What is new there? Well, first of all, what we pay attention to. Currently, the category of risk can and should be measured not only with the help of score, as we used to do it before, but also we should use additionally ultrasound study of carotid arteries or MSCT to look at coronary calcium. Score scale has also changed because we have now the group of 70 years old, because normally it was ended with 65 plus and nothing else. Then cholesterol level, maximum cholesterol level reduced from 8 to 7, and this is why, very clear why. And finally, from the additional risk factors, atherosclerosis, we have lipoprotein alpha small. And what is very important, target level of lipids were changed in different categories of cardiovascular risks. So for the category of very high risk, the target level of LDL currently is 1.4 instead of 1.8, as it used to be before. Now we see the category of extremely high risk, where the target level of LDL is less than 1. And this is also very important. And now I would like to show the portrait of this person, and this is academician Anatoly Klimov. And I was lucky enough to work under his leadership for many years. And you all remember very well that one of the results of his work was that he invented cholesterol heterogeneity index that we are actively using in Russia until now. So what is that? So let's look at this heterogeneity coefficient. You know very well that here we see a difference between the total cholesterol and HDL cholesterol, and in the denominator, it's the HDL level. So, and this is very well known. It's non-LDL cholesterol, and this is exactly non-LDL cholesterol. So regardless the treatment of statins, successful treatment, effective treatment, but still there is high risk of cardiovascular events, so-called residual risk. So this is the Scottish study, TNT study, and everywhere this risk is pretty high, although we have still good and effective statins. So today, again, we were talking about mixed dyslipidemia, and mixed dyslipidemia, this is more exact name. If we speak about heterogenic dyslipidemias, so it can mislead doctors because heterogenic dyslipidemia is actually high level of LDL. Mixed dyslipidemia means that high level of TG and low concentration, and you see how frequently this situation is prevalent, especially in patients with diabetes with high cardiovascular risk. And this is really obvious. If we speak about the modern approaches, then we are the doctors mainly based upon LDL level. We'll look at LDL level. And even the effective reduction of this parameter does not eliminate the complete residual cardiovascular risk. And in this context, we are looking at other targets of treatment, including non-LDL cholesterol. And I would like to say a few words here. In fact, what is non-LDL cholesterol? If the concentration of non-LDL cholesterol, they are directly correlating with the TG level, whereas the link of cholesterol and LDL is much weaker with TG level. We know that LDL cholesterol concentration is calculated by Friedel formula, and this is very well-known formula, and they use it in all the labs. So that means it's estimated parameter. First of all, it requires first 3 measurements of 3 parameters: total cholesterol, TG, and LDL. It is very well known that estimated LDL is becoming less precise with increased level of TG, for example, in diabetes patients. Speaking about non-LDL cholesterol, so this is more reliable tool for screening, especially in patients with hypertriglyceridemia, which requires measurement of just total cholesterol and HDL cholesterol. This is extremely important. So if we talk about how concentration of non-LDL cholesterol related to the cardiovascular risk, so we may demonstrate several studies. And one of these studies, and this is pretty old one, of 2001, the objective was to assess the influence of non-LDL cholesterol to the cardiovascular mortality and compare the role of non-LDL cholesterol and LDL cholesterol. So more than 4,000 participants were included into this study. So all lipid parameters were assessed. What appeared to be that non-LDL cholesterol, both in male and in female, appeared to be a more significant predictor of mortality during the whole period of follow-up. That was extremely important. That was more important than HDL. Another study, 1,500 patients, the average age 61, with ischemic heart disease and multivessel injuries, were followed for a number of years. The primary endpoint, non-fatal MI. What were the results of the study? Here you can clearly appreciate that non-LDL cholesterol, and here it is shown here, this is column on the right. This is a very strong and independent predictor of non-fatal MI within 5 years of prospective follow-up, which was much higher than LDL level. And another study shown here, which we all know very well, this is Paul Ritker study of 2005. Here you see huge number of patients, more than 15,000 healthy females aged 45 plus, were followed up for about 10 years to find MI, coronary revascularization, or mortality from cardiovascular reasons. And the participants were split according to the quintiles from distribution of total cholesterol or LDL cholesterol, non-LDL cholesterol, and the ratio ApoB to ApoA. It appeared to be that high level of non-LDL cholesterol appeared to be most significant predictor of the future cardiovascular events, except ApoB, because that was also a very strong predictor as well. This is another study dated 2010. 21,000 patients recruited without diabetes were followed up for about 10 years. So there are studies of the whole lipid spectrum, and the ischemic heart disease and mortality rate was analysis, the patient records and the death certificates. This study showed the following. From all lipid parameters, non-LDL cholesterol appeared to be the strongest predictor of ischemic heart disease in males. This is a very important parameter, a very important observation. Another study, you can appreciate it here, almost 5,000 patients who passed through the procedure of intravascular ultrasound for the assessment of atheroma size. It appeared to be that non-LDL cholesterol had a linear association with the size of the plaque. That means it was much more important to influence the level of non-LDL cholesterol versus just LDL cholesterol in order to influence the size of the plaque. And this is the other study. This is a really giant study. This is so-called cardiovascular consortium data. Here you can appreciate 500,000 of those who were examined from 44 different cohorts. And the maximum period of follow-up was 43 years, and the average period of follow-up was 13 and a half years. You see, during this follow-up period, there were almost 55,000 of cardiovascular events. So it appeared to be that 30-year event rate in the group of female with a level of non-LDL cholesterol less than 2.6 was just 7.7%. And with a level of non-LDL cholesterol higher than 5.7 millimole per liter was 37.7%. And in males, the rates were correspondingly 12.8% and 43.6%. So non-LDL higher than 5.6, 5.7 is really, really dangerous. And 50% reduction of non-LDL cholesterol was associated with reduction of cardiovascular risk up to 75 years. And the earlier the treatment was started, the stronger was the effect. So what do we see in the recommendation? Non-LDL cholesterol actually is included into the American guideline, specifically ATP3. We can appreciate here that in patients with a high level of TG, non-LDL cholesterol should be considered as a secondary objective of treatment, and this is extremely important. Now, NICE, these are British guidelines, British regulator, National Institute of Healthcare Excellence. So they pay really big attention to non-LDL cholesterol in the prevention of cardiovascular diseases. They say that non-LDL cholesterol is a stronger predictor of ischemic heart disease than just LDL. And before you start the treatment, it's recommended to make analysis, full blood test on all lipids, specifically calculate non-LDL cholesterol to estimate it, because this is estimated parameter, as we said before. Here are recommendations of American College of Cardiology, ACC of 2016, and then American Association of Clinical Endocrinology guidelines of 2017. In both options, we see that non-LDL cholesterol is valued greatly. And also, they report these particular threshold levels, about 2.6. And last but not least, this is European and these are Russian guidelines, where we can clearly appreciate, and this is class of evidence 1, a level of evidence is C. We see that secondary target levels of non-LDL cholesterol should be less than 2.2, for the patients of a very high risk, less 2.6 for the patients of high risk, and less 3.4 in patients of moderate risk. And summing up, I would like to emphasize that regardless of the statin treatment, still in vast majority of the patient, we do preserve quite high residual cardiovascular risk that mainly is due to the lipid disorders. So non-LDL cholesterol, as you can appreciate, has bigger prognostic importance than just LDL, especially in patients with diabetes and with metabolic syndrome. Non-LDL cholesterol is simpler, easier, and cheaper in the detection. Specifically, it does not require fasting. It is estimated using the level of just total cholesterol and HDL cholesterol. And thank you very much for your attention. Well, thank you very much, Professor Konstantinov. Yes, very interesting presentation. Many thanks for reminding us main positions of new guidelines on the atherosclerosis, and truly reminded us the significance of this very important and prognostically valuable parameter, non-LDL cholesterol, especially in the selected categories of patients. And I would like to thank you for the commemorate of academician claim of your teacher and your lead, because really the priority of the Russian school on studies of atherosclerosis started exactly from the time when cholesterol infiltrative theory offered by Professor Anichkov started from that period, and then continuation of Russian publications, Russian researchers, Russian studies, and we should always recollect that. We should always remember that. And now let me go to the Q&A session, and we accumulated very many questions. And let me start from the first question, which is actually to Andrei Obrizan. Professor Obrizan, are you with us? Yes, I'm here. Our doctor from Novgorod is asking, can I administer Omacor to a patient with a high risk instead of statins if CPC is less than 4 level of norm and there is myopathy during examination? Well, dear Vladimir, dear colleagues, definitely omega-3 puffers, even Omacor, will never replace the treatment of statin, which is primary first line of treatment. So my suggestion in this case would be the following: to understand where myopathy comes from, where hepatocytosis, try to correct it, and still refer to the statin treatment, well, possibly in combination with Omacor. Then the second option, try to go on azitrol plus possibly Omacor, because it would increase low-density lipids, and the second risk factor, TG, would be reduced. But again, it would be, let's say, off-label treatment. Still, if cholesterol is high, we can go to PCSK9, and some elements still can be offered here. So yes, we can, and most probably in combination with statin, again, re-examine the patients and find the reason of myopathy, or to find the statin would be the backbone treatment and Omacor would be add-on. Well, thank you very much, Andrei. Thank you very much for a very comprehensive answer. And the next question to Professor Gurevich. Our audience is asking, is there any additional benefit of combination of statin and fibrate to influence cardiovascular events, event rate influence? So yes, this is a very good question, which actually sums up all the discussion points we could have when we discuss our current topics, dyslipidemia. And by the way, Andrei, coming back to your report, on the fact that it should be statins, the inhibitors PCSK9, but if in this case there would be intolerance to statins, so we have no other choice, and we should use ezetimibe together with PCSK9. That's exactly what you've started with. Now coming back to the additional reduction of cardiovascular risks in combination with statins and fibrates, then yes, this is exactly how we can interpret the data of several trials, recent trials, significant trials, starting from ACCORD and starting from FIELD. Yes, really, we have additional reduction of cardiovascular events rate due to the fact that there is a field of residual risks which is reducing. That's why this combination would be affected by the direct purpose, reducing of the cardiovascular risks. Maybe some of the colleagues would like to add on something here to what was said before. Well, in fact, each of us will provide a position, although I believe that that would be interesting. If there are any comments, we can continue our discussion consecutively. Well, distinguished colleagues, now another question to Professor Gurevich. I think this question is induced by the mentioning of the diabetes. The question is like this. Anti-hyperglycemic treatment, pioglitazone, in the studies demonstrated reduction of TG and small LDL in blood plasma. Is it possible PCSK9 and statins can be used in combination? Yes, I see that this is an endocrinologist who is asking this question. Yes, it is possible, briefly speaking. If the short answer is yes, because if the patient has diabetes, then automatically it belongs to the category of very high cardiovascular risk. And then we should give the patient statin, for sure, for sure. Beside hypoglycemic tools. And by the way, among hypoglycemic tools, we also have particular priorities, specifically in the Russian guidelines. And we spoke a lot about this. The use of DAPA. And you know very well that it facilitates the reduction of cardiovascular risks. What you are speaking about, combination with PCSK9, with the inhibitors, well, possible, but yet not quite well established, at least now in the clinical practice. These drugs are pretty expensive. So we are trying, together with Victor and with other colleagues, we are trying somehow to actually provide this treatment to the patients who really need. Regional or federal budgets. And this is not quite available, I would say, not quite affordable, better say. But I think this is quite a reasonable question and feasible question, and such combination is possible. Thank you very much. Well, thank you very much, Professor Obrizan. Yes, you would like to add on something? Yes. I'm speaking like a GP, so there is no need to add on to Professor Konstantinov, but I would like to mention that rosiglitazone and pioglitazone, and Vladimir, you know that very well, still the trend to MI and CHF is increased. Unfortunately, it happens because these two very well-established drugs, although they are reducing LDL, at the same time, they are increasing CRP, so there is some pro-inflammatory potential behind them. That is why these drugs are not recommended in the cardiological community in any atherosclerosis-associated pathology. And Vladimir possibly confirms that probably SGLT2 inhibitors, group 1, and this is line 1, yes, they will also influence lipid factors positively as well. Then the second line, biguanides, and then later the rest will come, but it will never be rosiglitazone or pioglitazone, although there are great trends in the reducing of lipids. And if the patient is still on this treatment, that Vladimir was absolutely right saying that here we need to administer statin as a must, because statin, due to the pleiotropic effects, especially rosuvastatin, would additionally reduce this high CRP or canakinumab. You're welcome. Sorry for my comment. Well, Andrei, that's very valuable. That's very valuable comment. And let me comment on the endocrinology community, this specific issue. I think that's the point. That's exactly the discussion, because we are discussing the aspects which actually merge us together, interdisciplinary specialists in different areas. It's exactly here I would like to tell you, in the endocrinology, in diabetology, they used to believe that our task is to reduce cardiovascular risks. So that's exactly the consensus that is absolutely obvious for everybody, cardiologists, endocrinologists, and reduction of hyperlipidemia, dyslipidemia, hyperglycemia, reduction of BP. So these are exactly the most important targets that we are setting for our patients. And they were not reported any negative drug-drug interactions in case of pioglitazone, rosiglitazone, and the drugs that potentially may influence the reduction of lipid levels, which are statins and PCSK9. So roughly speaking, it is recommended to manage these two conditions, hyperglycemia and dyslipidemia, regardless each other, with the tools which we believe essential. So, and if there are indications, yes, we have to do it. And Andrei, I disagree about this class of drugs, thiazolidinediones, TZDs, because everything that refers to the heart failure, it's not about them. It's mainly about rosiglitazone, and all that negative story was related to that mainly. But pioglitazone, very recently in 2016, in one of the evidence-based studies, it has been shown opposite of the reduction of the non-fatal MIs and non-fatal strokes and fatal MIs at the same time in patients even without diabetes, but just with insulin resistance. So mainly it refers not to the MIs, but to the heart failure on TZDs. And I believe that, yes, if we are discussing the combination with SGLT2 inhibitors that successfully is removing excessive fluids, I believe such combination TZD with SGLT2 will minimize the effect to the fluid retention and the risks that they demonstrate in terms of increasing hospitalization because of heart failure. Distinguished colleagues, well, this question immediately pops up after this round of discussion. SGLT2 inhibitors associated with particular increased level of LDL and HDL. This effect can be stronger if canagliflozin is administered. What is the practical titration of cana, keeping in mind statins as a backbone treatment? So once again, it proves us that really we are discussing now the topics of hypolipidemic treatment, interdisciplinary, and our audience are the people who are presenting very different specialties. Definitely there are endocrinologists, there are GPs, there are cardiologists. So from here we have very different questions. So if you allow me, I would like to make it a little bit more detailed about SGLT2 inhibitors and their influence to the lipid profile. What is your position? Do you think it is the class of drugs that can be considered as effective agents on their mechanism of action or not? Who would like to take this question? Yes, I would like to make a comment here, if possible, because in the recent years, truly, our very fruitful cooperation with endocrinologists, it brings both positive and controversial things, and also it creates new questions, which is very good. It's not easy to answer, and I would like to clarify the terminology. In this specific case, and I hope you agree with me, we should not speak about the combined treatment. So this is parallel use of different drugs with, and if there is any influence to the lipid profile, it's complex results from the point of reduction of cardiovascular risks, and I totally agree with that. But this is not yet combined treatment, but let's say parallel treatment with different groups of drugs, and this is how we have to interpret these different minor changes in the lipid profile, or let's say fluid retention or salt exchange. So it would be easier to resolve it. So because this is exactly a group of 5 drugs that we know very well today, but the rest, let's say, including antagonists of calcium that do have anti-androgenic effect, or let's say sartans, it's all the same. We are considering them, these minor properties, let me call it this way, when we resolve the issues about the administration of parallel treatments, hypertensive treatment specifically. But the direct hypolipidemic effect is typical only for those drugs that we are talking about today. And I think, yes, this is quite bulky response, yes. But nevertheless, I believe this is a very good response to this question, because really, if we can talk about particular nuances about the influence of this class of drug, that this is no more than, small, very small pleiotropic specificities, but not the hypolipidemic effect. So this is the final question, because we are already a little bit behind the schedule. This question is not specific to anyone. In familial hypercholesterolemia without cardiovascular events, what could be the maximum doses of statins, dear experts, that are recommended to use in combination with ezetimibe? Familial hypercholesterolemia without cardiovascular events. Can I take this question? Yeah, sure. So if familial hypercholesterolemia is proved, let's say heterozygote or homozygote forms, then we need to use maximum tolerable doses of statins in combination with ezetimibe. If there is no effect from this treatment, then please use PCSK9 inhibitors as add-on on top. Monoclonal antibodies or new drug inclisiran, which I believe will come to our market very soon. But actually, we have to start from the maximum tolerable doses of statins in combination with ezetimibe. Well, thank you very much. Thank you very much. Any other positions about that? Any other comments, remarks? Well, if not, then thank you very much, dear experts, and many thanks to our distinguished speakers that presented their positions on the most interesting and most disputable issues in the curation of dyslipidemia, in the diagnosis and treatment. And they used the practical approaches and so once again, we would like to thank our experts. And before we go for break, and currently we are expecting break in St. Petersburg Hall up to 2:15. So we are coming back to this hall at 2:15. And I would like to announce right now that at 2:15 we will start another very interesting symposium that will be devoted to the issue of arterial and venous thrombosis. This is the symposium that will be broadcasted from our hall, and it will be presented by colleagues from Kazakhstan, from Italy. So I hope that will be extremely interesting discussion of the most interesting, unique, most relevant and hot disputable topics in this area. So with that, let me wrap up this symposium on hyperlipidemic treatments, and welcome back at 2:15. Have a nice day. Goodbye. Enjoy your break.
В ваших руках возможность замедлить прогрессирование хронической сердечной недостаточности. Какова цена промедления?
Раз, два, три, четыре, пять, один, два, три. Вот такой уровень, я тебе стараюсь, как бы я всегда его держу.
Итак, глубоко уважаемые коллеги, еще раз всех
Distinguished
приветствую.
colleagues, welcome everybody.
Мы
Well, welcome
продолжаем
everybody
трансляцию
after the break.
из зала
We
Санкт-Петербург,
continue our broadcast from the hall
зала,
St. Petersburg.
который носит имя
This is the
как раз
hall
того города,
which
откуда
is
эта
named
трансляция
of the
идет,
northern
одного из
capital
самых
of
прекрасных
Russia.
городов России.
It is exactly
Ну, в
from
этом
where
доме
we are
было просто
broadcasting
красиво.
today, St.
И я
Petersburg.
думаю, что
This is one of the
то
magnificent
мероприятие,
cities
которое
of
нам
Russian
сейчас
Federation,
предстоит,
and
именно
the event
симпозиум,
that we're expecting
посвященный
now, and this is a session
посвященный
devoted
артериальным
to
венозным
the
тромбозам,
arterial and
симпозиум,
venous
который
thrombosis.
наверняка
This is the
привлечет огромное
symposia that will
внимание
definitely
нашей
attract
аудитории,
huge attention of our
поскольку,
audience,
безусловно,
because
вопрос
definitely
кровопотей в последнее время, в период пандемии новой коронавирусной
because
инфекции,
during the pandemic of new
мы стали
coronavirus
разбираться
infection,
все в эти
we are
вопросы,
going to
оказывается, потому что мы
deal
абсолютно
deeper
не
into
случайны.
that because,
И
yes,
я с большим
this is
удовольствием
very
хотел бы
interesting. And it's my
номинировать
greatest pleasure
первого
now
докладчика.
to
И
announce
значительная
our
часть
first
докладов
speaker,
будет
and
от спикеров,
vast
которые,
majority of the
так сказать,
presentations today would be
работают и
made
будут
by the
представлять
speakers who
Астану,
will introduce
Алмату.
Kazakhstan, Astana,
И в частности
Kazakhstan,
сейчас я
Almata,
представляю слово
and currently
Жангелову
I'm giving
Шалбану
the floor
Булатовой,
to
которая
Dr. Zhangelova, who
является профессором кафедры
is
внутренней
the
болезни
professor
Казахского
of
национального
internal
медицинского
chair of
университета
Kazakh National
города
Medical
Алматы.
University, Almaty,
И тема доклада,
Kazakhstan.
который
And the topic of the
Шахбан Булатовна
presentation we are
сейчас
expecting from
доложит, принципы
Dr.
профилактики венозной
Zhangelova, the
тромбоэмболии у
principles
беременных,
of
в том
prevention
числе
of venous
при
thromboembolia in
COVID-19.
pregnant, including
Шахбан Булатовна,
situation of
слышите?
COVID-19. Can you hear me?
Слышите
Please
меня?
confirm.
Хорошо,
Yes,
пожалуйста,
we
вам
can see
слово.
you and we can hear you. The floor is yours. You're welcome. Thank you very much. I would like to express gratitude for the invitation to participate in the Congress, and I'm welcoming everyone who is here with us today in Hall St. Petersburg, who is interested in the venous thromboembolia prevention. So this is exactly what I'm going to talk about, with the focus on pregnant, with the focus on COVID-19. This is Kazakhstan Republic, and this is some statistics. By January 1st, 2020, we have 18.6 million population. Pregnant by September 1st, more than 500,000, 527,000 pregnant. Deliveries by September 1st, 302,000. For total 2019, we have 390,000 deliveries. So we actually head-to-head with the previous year. So it's not high delivery rate per population. But from April to September, we registered 4,851. 4,851 pregnant and after delivery women with COVID, 41 fatality just among this pregnant group. And in our medical college, we had the presentation just for 8 months of this year. We already lost 131 pregnant. 131 pregnant versus previous year. Mortality tripled versus last year among pregnant. So these are charts on top, January, February. You see how fatality is increasing among pregnant, doubling. 6 versus 11, 3 versus 6, 6 versus 5. When there was stringent quarantine, March, April, fatality dropped down. But again, since May, it's tripled. There were 3 in 2019, and now it's 9. And the same trend in June, July, August. Among the reasons of maternity deaths, it's increased versus previous year, and we see a high number of pneumonias, twice more with pneumonias and thromboembolias, 3 times more thromboembolias and 2 times more pneumonias. That's why we have a very serious question: how to prevent thromboembolic complications of COVID-19. So these are our facts and this is our statistics. We know that during pregnancy, the risk of venous thrombosis is doubled. And this risk is increased with gestation period, and the peak is right after delivery. It's 5 or even more times higher versus non-pregnant. Mainly, we deal with thromboembolic complications in those who are right after delivery, postpartum females, post-cesarean, post-delivery, postpartum. But now they are pregnant, and during pregnancy, they already have thromboembolic complications, and we are very much concerned. We are very much concerned. And we should remember that the risk of venous thromboembolism is additionally increased with additional risk factors, not only obstetrical, but also extragenital pathologies, as well as in presence of COVID-19, if patient is positive. And here, I would like to introduce our tactics of pregnant and postpartum management with COVID-19. This is our Kazakhstan clinical protocol, which is approved by the Ministry of Health. According to this protocol, all pregnant with COVID-19, moderate grade in the middle and severe on the right, should be hospitalized first. They should be hospitalized. That's first. And all our protocol based upon international guidelines of ISIDOG recommendations concerning COVID-19 and pregnancy. So we copy-paste from there. According to this consensus, pregnant who do have extragenital pathology are a special group of very high risk for the development of severe course of COVID-19. Why? Because they demonstrate a very fast respiratory failure, very high risk of miscarriage, respiratory distress syndrome, premature delivery, and high risk of perinatal complications. And according to these documents, we still keep in mind, nota bene, pregnant with COVID-19 is a very high risk group in obstetrics. It could be sudden critical condition with more or less stable COVID-19, but then sudden worsening. And then keeping in mind high risk of coagulopathies and hyperfibrinolysis in pregnant and postpartum with COVID-19, it is recommended the control of all coagulogram, INR, APTT, fibrinogen, platelets, hemoglobin, and the frequency of tests depends on the severity and the use of anticoagulants. But anticoagulant treatment during pregnancy and postpartum has its own specificity. That is why, in my next slides, I will show you just the principles of anticoagulant treatment. First and foremost, when we face pregnant patients with COVID-19 positive, we have to assess risk of thrombosis by Caprini scale. This is the model of thrombosis risk assessment by Caprini here on the top. And specifically a female section, I squared it in red. After the selecting points, so we put ticks, then we count, we measure what is the score, how many points, and then we see what is the risk group. According to the risk group, there will be a particular regimen of thrombus prevention. Definitely, there are contraindications for the medical thrombus prevention, and these documents should be signed by the doctor. The date should be here, and it will be part of the medical records. That means in the medical records, we should have these Caprini scale assessments. What else? We put there a model of bleed risk assessment because this is anticoagulants. So we have to assess bleed risks, and we use improve scale for that. So we select points according to the symptoms, according to the functional status, and high risk if it's 7 or more, low risk if it's less than 7. Patients with mild COVID-19, the prevention of venous thrombosis is not indicated. It is based upon the approaches of ACCP community. This is American College of Cardiology and therapists. And here we have the profile of the pregnant of those who need thrombus prevention during the pregnancy and after the pregnancy. So according to this position, the total population does not require thrombus prevention. But females, those who have thromboembolic history in the medical history or family history, positive family history, or thrombophilia or hereditary mutations, Leiden or prothrombin, these females need this prevention, no matter whether they have COVID or not. These patients, we need thrombotic prevention. antithrombotic treatment. If pregnant is hospitalized with COVID-19, that means she is moderate or severe. That means we measure D-dimer, prothrombin time, thromboplatelets, fibrinogen, creatinine, and estimated GFR. And we should always remember that during pregnancy, D-dimer physiologically increased with each trimester by 39%. So please take a picture. Take a picture of this chart. You see yellow is the first trimester, orange is second trimester, and the pink one is third trimester. Please keep it in mind. Keep it in mind. And the green is non-pregnant. So if D-dimer is higher than these levels, so frequently, very frequently, it may create thrombus. D-dimer increase more than quadruple norm from this baseline level is really indicator of very bad prognosis. And we should remember that all pregnant with COVID-19 who are in severe conditions, we should perform the ultrasound of the lower extremities vein to diagnose DVT, deep vein thrombosis. All pregnant COVID positive who are hospitalized in the COVID dedicated hospitals, no matter what is the gestation period, international experts recommend to use interim preventive dose of low molecular heparins, which is 50% from therapeutical, 50% from therapeutical, which is calculated per patient weight, split into two, BID. Why? It appeared to be that preventive doses of low molecular heparins increased both venous and arterial thrombosis by 27%. So preventive dose is not enough. It should be half of therapeutical. Nadraparin and enoxaparin in moderate and severe patients, dose would be 0.4 milliliters BID. Fondaparinux, preventive dose is 2.5 milligram. Heparin, 5,000, 3 times a day. And the principles of pharmacological thrombus prevention. Patients with creatinine clearance higher than 30, we need to administer low molecular heparins. Patients with creatinine clearance less than 30, it's non-fractionated simple heparin sub-Q 2-3 times a day or IV. If she demonstrates thrombocytopenia, the drug of selection is fondaparinux. And patients who are in ICU and high level of D-dimer, severe inflammation, ARDS, liver or kidney failure, it should be therapeutical doses on non-fractionated heparins or low molecular heparins. Anticoagulants in therapeutical doses, that means all patients with high risk of venous thromboembolism in DVT, in TELA, and also for the treatment of ARDS, acute respiratory distress syndrome, even if we don't see DVT, or if we don't see TELA, if we see ARDS. With COVID positive, when we confirm TELA or deep vein thrombosis, we should follow TELA protocol. Therapeutical doses of anticoagulants, they are counted from the patient weight. So this is 0.1 milliliter per kilo of weight. This is nadraparin. If weight is less than 50, the dose is 0.4 BID. If the weight is 50-59, then 0.5 BID, 60-69, 0.6 BID, etc. Enoxaparin, 1 milligram per kilo BID. Fondaparinux by weight, less than 50 kilos, 5 milligram, with body weight up to 100 kilos, 7.5, 100 plus kilogram plus 10 milligram. Heparin, initial dose, 80 units per kilo as a bolus, with a further induction 18 units per kilo per hour. And then we measure APTT in 4-6 hours after the bolus of heparin. It should grow in 1.52 times. And if you don't see that, that means we need to increase heparin dose. And later, every 3 hours after the increase of dose, we measure APTT until we reach therapeutical doses. The heparin dosing regimen will depend on APTT. But you simply should remember that if APTT is higher than 90 seconds, then we stop infusion for 1 hour, and then we reduce by 3 units per kilo per hour. And definitely we need to remember that lactating and pregnant, we never use anticoagulants per os, never. In pregnancy, we can switch pregnant to week 36 to low fractionated simple heparin, and in these cases, we need to stop it for 6 hours before delivery. Low molecular, we stop 24 hours before expected deliveries, and complete discontinuation is needed if we need regional anesthesia. And epidural anesthesia cannot be used within 12 hours after the use of preventive dose and after 24 hours after therapeutical doses. And postpartum delivery is identified by interdisciplinary consortium. So the beginning of anticoagulant treatment in patients with DVT or TELA, it depends on the method. And of course, we are balancing between the risk of thrombosis and the risk of bleed. We are somewhere in between. That's why definitely we need concilium. Low molecular heparin can be administered in 4 hours after the removal of epidural catheter. You can administer preventive dose in 4 hours. Then after the risk assessment, after the removal of the catheter, with the interval of 8 to 12 hours, we can administer second preventive dose. So anticoagulant treatment should be provided 6 weeks postpartum with a minimal duration up to 3 months. You can use low molecular heparins and warfarins during lactation. Pharmacological prevention is contraindicated in obvious bleed, in a high risk of bleed, and if you are doubted in the surgical hemostasis. If it's a failure, then we provide mechanical thrombus prevention using elastic compression or intermittent compression. Our patients after the hospitalization of COVID-19 should get routine anticoagulant treatment in the preventive doses, low molecular heparins not less than 10 days, even in the absence of other risk factors. And duration should be guided by the clinical manifestation, by level of D-dimer, coagulogram, the dynamics, computer tomography or X-ray. And if pulmonary artery thromboembolia, PATE was diagnosed, then we follow this protocol, pulmonary thromboembolia, PTE or PATE. So they should be prevented at least for 6 weeks. And wrapping up, I would like to speak about key messages of my presentation. What are the principles of thromboprophylaxis in pregnant? You should remember that pregnant and postpartum with COVID-19, this is a high risk in obstetrics. With extragenital pathology, this is a group of very high risk for the development of very severe course of COVID-19. With stable COVID-19, please remember that we can see sudden, unexpected beginning of the critical condition. All pregnant with moderate or severe COVID-19 should be hospitalized. All hospitalized pregnant should get parenteral anticoagulant treatment by interim doses after the risk assessment by Caprini and improve. If there is DVT, PTE, or ARDS, there should be therapeutical doses of anticoagulants. NOACs are not used in pregnant and lactating. And after the hospitalization of pregnant with COVID-19, anticoagulant treatment should be continued up to 10 days when there is no PTE, or up to 6 weeks when there is high risk group, or up to 3 months if there was DVT or PTE. Thank you very much for your attention. The previous Eurasian Congress had to take place in Almaty, but we were in lockdown. There was no physical Congress in Kazakhstan, so I do hope that one day the Congress, Eurasian Congress on Therapists, will come again to Kazakhstan. I'm welcoming you. So now it's a season of aporta, and I would be happy to give you some aporta to try. Thank you very much. Stay healthy. Thank you very much. Thank you very much Dr. Jangalova, for your invitation and for absolutely brilliant and very interesting presentation. Well, I believe that each of us colleagues were very much impressed by the beginning of the presentation by Dr. Jangalova. Dramatic figures of those pregnant and postpartum females that died because of COVID pneumonias. Definitely, it looks very impressive, very impressive. And if you act as Dr. Jangalova recommended according to the international guidelines and these practical approaches, we will be able to minimize these very unfavorable outcomes. And let us proceed our agenda. I remind you that today we talk about, in this session, we speak about the arterial and venous thrombosis. The next speaker would be Dr. Junusbekova. And once again, announcement. At the end of this session, we are expecting Q&A session because we see how many people are with us online in the webcast. So we are expecting Q&A. Q&A, that means we will have questions you are allowed to send to our web chat. So that's why we encourage you. Please don't hesitate. As soon as you hear or see something interesting of one particular aspect, please provide your questions, comments, remarks, and please note who this question is referred to, who are the experts. And now we do proceed the symposium, and it's now my greatest pleasure to introduce Dr. Junusbekova, who is the president of Therapist Association in Kazakhstan, and she is the lead of cardiology of chair, professor, doctor of medical sciences, and her presentation is entitled the following: Clinical Portrait of the Patients with Acute MI in Republic of Kazakhstan. So what happens with MI patients in Kazakhstan? Gulnara, can you see us? Can you hear us?
Так, ну у нас сейчас возникла определенная техническая проблема. Так, я думаю, что сейчас мы попробуем ее устранить. Ну, а пока я хотел бы еще раз обозначить, что та тема, которую мы сегодня обсуждаем, очень ассоциирована с днем сегодняшним, поскольку действительно COVID-19 – это тот самый вызов, который серьезно трансформирует все наши медицинские специальности. И действительно, вот та тема, которая сейчас прозвучала,
So the topic which just was mentioned, and we are waiting for it's a bit of technical delay. We apologize. So we heard in the first presentation what we do with pregnant patients with COVID. Now we know what we can do.
Ну и позвольте еще раз предоставить слово, пожалуйста.
So once again, we'll give the floor to Professor Junusbekova. So we do apologize for this technical delay. On my behalf, I would like to confirm that I'm very happy to be a part of this large-scale forum, and I would like to thank for the opportunity to speak up here. The topic of my presentation is not directly related to COVID. I would like to speak specifically about MI and to present our statistical data in Kazakhstan and to say what is the patient journey with MI in the Republic of Kazakhstan. Just recently, we published a very new analysis of the main reasons of premature mortalities related to the loss of employment. And you can appreciate it. This is publication of Lancet. And you see for both genders in 2019, after neonatal disorders, and this is actually a topic which deserves a separate conference, and the first presentation already covered that. Then we see ischemic heart disease. It's number two, which is 72% of daily parameter. The parameter popped up from number 4 to number 2. And if you analyze separately this population, the age 54-75, so this is a traditional place of ischemic heart disease, number 1, both in 2019 and 2020, and the contribution to daily is 1.8%, quite a lot. And then in the same analysis, if we look at the countries, we can analyze the probability of death in percentage. depending on the chronic diseases. For Kazakhstan, we can appreciate that for females, it's a probability of about 10%. For males, it's a probability of about 20%. This is the mortality related to the ischemic heart disease. In terms of intensity of the color, we see that, yes, this is very high contribution. And also, we can appreciate, if we compare with other countries, that the intensity for this parameter for Kazakhstan is one of the highest. If we refer to the official statistics in Kazakhstan, so we can appreciate that for about 20 years, we have stable trends to increase the incidence. Incidence is decreasing. And we have many newly diagnosed patients because there are very prevalent risk factors. And also, we see that the identification is getting better and better because from 2011, we have a national screening program to identify cardiovascular diseases, specifically ischemic heart disease and type 2 diabetes. So every 2 years, patients who are 40 plus are actively screened. And if we appreciate the mortality, which is red curve here, we see clear trend that mortality is reducing starting from 2009, exactly when we had big healthcare problem for the development of interventional cardiology and cardiosurgical options. This is MI data 2019, totally 18,433 patients. You can appreciate it here that among these patients, in 74% of the cases, we had coronary angiography, 74%, and half of them were stented because only 3% of patients had thrombolysis. Now, speaking about mortality from ischemic heart disease and its contribution into the mortality, well, here you see that ischemic heart disease gives 37% and 6% from acute MI. And in the structure of ischemic heart disease, MI takes 17%. And we see the same trend to reduce specifically from 2009, because in each region we launched cardiosurgical interventional centers. If we analyze the incidence and mortality in the regions, so you can identify the following. There is particular variability in terms of incidence in between the regions. In fact, not much difference. But speaking about mortality, then mortality is much higher in Karaganda, in northern Kazakhstan and Almaty, so in the regions where we have, let's say, more elderly population. So these parameters are not adjusted by the gender and by the age. And the same trend for the death rate and mortality rate with the prevailing in the northern parts and in the eastern parts of Kazakhstan and Almaty city, where we have more elderly population. And plus to that, Almaty is a very big city with particular risk factors, plus some issues of ecological issues, so here mortality is higher. And due to that, I would like to briefly show you the patient portrait with acute MI in Almaty city. And this is analysis of those patients who were hospitalized in 2019 to the city cardiology center. So this is the largest center, which is providing emergency cardiology care to the patients with acute MI. And it is led by Professor Padaspayev, who is the lead of the cardiosurgery chair in the National Medical University where we are working. And the cardiology chair actually carried out this analysis. So you can appreciate 633 patients with acute MI. This is retrospective analysis. The average age was 65.4 years. And then 3%. So 3% of younger patients, then average age 25%. elderly age 51% and 21% patients of elderly and very elderly age, centenarians. 64% males, 36% females. If you look at the type of MI, 34% that was STEMI and 66 non-STEMI. So from them, the secondary MI was in 32% of the patients, and bypass in the medical history was in about 16% of the patients. So what are the main cardiovascular risk factors typical for our patients, those who had acute MI in Almaty city? So you can appreciate here that every fifth one, actually 22% are smokers at the moment of the stroke, MI. 90% had MI with arterial hypertension. Every fifth one, 20%, were suffering with diabetes. 78% had were overweight or had obesity. Now, speaking about associated or comorbid conditions, we can appreciate that 9% had strokes in the medical history, 13% had atrial fibrillation, then GI diseases, erosions and ulcerations that later on matter in these patients. That was 11% of the patients, then chronic kidney disease, 25%. And the level of care presented here, coronography, 83% and 48% stenting. So that was 8 patients, 8% cabbage. Complications, cardiac arrest, cardiogenic shock, or ventricular fibrillation or relapse of MI, 8.5% of population. Clinical portrait of patients with acute MI in Almaty. So, as I told you before, this is quite prevalent non-controllable arterial hypertension, and you see here a very high percentage. 81% of the patients with MI had arterial hypertension grade 3. 76% had hyperglycemia, higher than normal rates. 26% had estimated GFR less than 60 milliliters per minute. 94% had more than 1.4 millimole per liter. And as you understand, for this population, that would be less than 1.4 of a targeted level of LDL. And ejection fraction, the average ejection fraction was 47.8%, and the reduction of less than 40% was seen in 29% of the patients. So this is the clinical parameter which confirms high comorbidity and high prevalence of different risk factors. And after the interventional and surgical treatment of these patients, we normally administer optimal conservative treatment. And then we have some data on the compliance to treatment of these patients with MI, during the first 12 months after the MI. And according to the Institution of Cardiology, studies was carried out in 2015, 2017 in a few towns in the several regions. So here you can appreciate data for Almaty city. So we see that this is 68, and for the region 73%, this is dual antiaggregant treatment, beta blockers after MI within first year 86%, and for the region just 50%, every second one. And no more than a third of the patients are getting statins. So you see that antiaggregants 60%, 50%, beta blockers, 30% statins. So what can we expect? Here we can appreciate that dual anti-aggregant treatment, less compliance, specifically with the administration of second drug, ticagrelor or clopidogrel, is reported in patients, in non-STEMI patients, which is 42%, with STEMI 65%. So here we appreciate the situation a bit better, but still not enough of statin treatment. And by the way, we have these opportunities for the optimal treatment and better compliance, because from 2017 we have reimbursed list of drugs, and here it is: patients with ischemic heart disease and acute MI after stenting of coronary arteries, after aortocoronary bypass, cabbage. Patients are reimbursed with drugs for free. And here we can appreciate ticagrelor as P2Y12 inhibitor, clopidogrel, aspirin, bisoprolol, amlodipine, atorvastatin. So, and also for the treatment of arterial hypertension, heart failure, atrial fibrillation, and definitely with diabetes. And so these patients are not quite compliant to the dual anti-thrombotic treatment, and clopidogrel is not frequently used because we see now the improved opportunities, because now we have generic of ticagrelor, which is called Triventin, ticagrelor generic. Now it's drug of a national manufacturer, Kazakhstan manufacturer, which is localized in Almaty. So currently they already included into the reimbursement list and they were registered, so they proved their bioequivalence and confirmed reproducibility. We have to say that our national manufacturer AIGP, they started actually working from 2012. So this is one of the first Kazakhstan manufacturers that got GMP certificate. That means they meet international requirements for the pharmaceutical production. They have a long history, so these are two giants as Abdi Ibrahim, and this is how they were developing starting from 1912. They have a long-term story, and in 2012, when they celebrated 100-year anniversary, this company was localized in Kazakhstan. And this is main partner of SK Farmats. You see that 86% of diabetic patients are getting the drugs of Abdi Ibrahim Global Farm. And you can appreciate here that totally 108 products in their portfolio, and 122 are regional, and generics are supplied to Kazakhstan and to neighboring countries. And in the recent guidelines on STEMI, as you know, there are new key recommendations. Specifically, there is higher level for prasugrel over ticagrelor for patients with non-STEMI, for patients with PCI, but unfortunately, in Kazakhstan, prasugrel is not registered. That's why, as a very powerful P2Y12 inhibitor, we can use ticagrelor specifically. And in this case, it is used without the escalation, which is having particular economical reasons frequently. And in these guidelines, we also see that the option is to administer without a planned strategy, so invasive or conservative, no matter. And this is my last slide. So this is the scheme of antithrombotic treatment for the patients with non-STEMI, patients with atrial fibrillations, where depending on the risk of bleeds, and patients with low risk of bleeds, long-term 12 months anti-aggregant treatment is a priority here, and also preferably in patients with ischemic risks, we can prolong 12 months plus with reduced doses. Thank you very much for your attention. Thank you very much, Professor Jusunbekova. Well, definitely, this is very interesting data. Every time when we get something new, new features, new science of clinical and laboratory picture of our patients with MI. So all that allows us to formulate clear vectors of management to organize preventive care and to identify earlier diseases. And now let's proceed our agenda. And the next speaker today, and this is our dedicated guest, Professor Plinio Cirillo, global expert who is representing Milano, Italy, who is a global, world-famous specialist in cardiology, and he's a professor of cardiology chair, Faculty of Innovative and Biomedical Sciences of Napolitano, University of Friedrich II. This is one of the oldest universities in Europe and the first state university, which was established in 1224. Oh my God, I cannot imagine that. Medieval age. The topic of the presentation of Plinio is shown here. This is the paradigm of dual anti-platelet treatment after OCS. Plinio, are you with us? Please share the slides and unmute.
Hi, thank you for your wonderful presentation. I'm very happy to be together with you in this international and very important meeting. And I want to thank you for the opportunity to be here with you. And I want to go on with my presentation about the dual antiplatelet therapy following acute coronary syndromes. And the first question about DAPT for this patient is why we have to prescribe the DAPT. And as you know, two platelet-mediated events can be observed in a patient with ACS. As you know, ACS pathophysiology foresee activation of the extrinsic coagulation pathway together with platelet activation. These two pathways converge to lead to thrombus from intracoronary formation. On the other side, if a patient is treated for ACS or for stable coronary disease with stent implantation, we can have another dramatic event, such as stent thrombosis. Both these phenomena are two platelet-mediated events. Thus, current guidelines recommend to treat our patient with ACS for not less than 12 months with the double antiplatelet therapy. I mean aspirin plus an inhibitor of P2Y12 receptor, the inhibitor for the receptor for ADP. And this is true for patients with ST segment elevation myocardial infarction, and as you know, for patients who experienced an myocardial infarction without ST persistent segment elevation. And this is known as standard DAPT. But at the end of 12 months, what have we to do? We have two options. The first one, his choice, is to stop DAPT. The other option is to prolong DAPT. So the other question is, why have we to prolong DAPT in our patient? And I want to show you few studies to support this hypothesis, this kind of choice to continue the therapeutic approach for our patient. The first one is the Apollo 4 country analysis. This is a very large registry that included more than 150,000 patients. They included patients from US and from 3 countries of Europe. And these studies demonstrated that up to a third of patients who are, and this is the important point, event-free for the first year after the acute index event will suffer a new myocardial infarction or stroke, 2 platelet-mediated events or death within the next 3 years. Another study from Thomas Pilgrim demonstrated that in patients with acute coronary syndromes, and especially in patients with STEMI or unSTEMI, the rate of myocardial infarction as well as of cardiac mortality continued to increase after 1 year. And this study was confirmed in a more recent study, that is the Sweden Art Registry, in which, considering a larger time window of about 10 years, they demonstrated that there is an increased incidence of acute coronary syndromes for non-culprit or culprit lesion in patients who had a first myocardial infarction. Finally, this study from Udell that evaluated the advantages of extend dual antiplatelet therapy as compared with a continuing of therapy with aspirin alone. And this study demonstrated that major adverse cardiovascular events, cardiovascular death, myocardial infarction, stroke, and stent thrombosis, one more platelet-mediated events, were reduced in those patients that continued dual antiplatelet therapy. The next question is, which drug? As you know, we have to choose which inhibitor of P2Y12 we have to choose plus aspirin to prolong DAPT. And as you know, we have 3 drugs, clopidogrel, prasugrel, or ticagrelor. These drugs share similar pharmacodynamics. However, they have several differences too, such as the onset of action that is very fast for prasugrel or ticagrelor, and it is, on the contrary, very slow for clopidogrel. But there are some differences and some concerns for these drugs. Especially, as you know, for clopidogrel, there is a variability in clopidogrel response for our patients, because about 80% of the drug, that is a prodrug, is inactivated in the liver. And I want to show you what does it mean that there is a variability in clopidogrel response. These are platelet aggregation curves that have been evaluated by LTA. In this panel on the left, you can see that platelet aggregation is completely inhibited in these patients treated with ASA plus ticagrelor, is partially inhibited in these patients treated with ASA and clopidogrel, and is not inhibited in these patients treated with aspirin and clopidogrel. These patients had clopidogrel resistance, and these patients was a patients that experienced a new ischemic event after stent implantation. Again, the prasugrel was evaluated in the DAPT study that evaluated the DAPT prolongation with prasugrel and aspirin. And this study showed that patients presented with a platelet-mediated event, such as myocardial infarction, had a better outcome as compared to patients treated with aspirin alone. However, those patients included in this study were patients treated only with interventional cardiology, so treated with PCI. On the contrary, ticagrelor was evaluated in a larger study, the Plato study, that evaluated the DAPT prolongation with the ticagrelor 90 or 60 milligrams twice a day in patients treated with PCI or medically treated that had an ACS, STEMI or unSTEMI. So current guidelines of the European Society of Cardiology, as well as of the American societies such as ACC and AHA, suggest to use ticagrelor over prasugrel on clopidogrel to prolong DAPT after 12 months. And finally, another question that for me is the most important question about DAPT prolongation is which are the patients that we have to treat with the DAPT beyond 12 months. And this study from Thomas Yerberg evaluated a large population of about 100,000 patients and demonstrated that patients older than 72 years had a worse outcome for an increase of cumulative incidence of myocardial infarction, stroke, or cardiovascular disease as compared with younger patients. Moreover, all the patients that were considered at high risk had a worse outcome. And as high risk were considered those patients with multivessel disease, coronary artery disease treated with bypass, patients with peripheral artery disease, with chronic heart failure, with diabetes, or with renal impairment. And a more recent study, always from the Sweden Heart Registry, demonstrated that age, chronic kidney disease, diabetes, prior myocardial infarction, and multivessel disease were responsible of a worse outcome for the patients who had acute coronary syndromes. And all these determinants of an high risk of newer ACS are the key inclusion criteria for the Pegasus TIMI 54 study that evaluated those patients with ACS, STEMI or unSTEMI, that had the better outcome derived from DAPT prolongation with the ticagrelor. And this is, for me, not one of the study that evaluated DAPT prolongation, but the study. Because in this study, we have a lot of results in several subsets of patients, patients with chronic kidney disease, patients with diabetes, patients with multivessel disease, and patients with peripheral artery disease. So another point to consider if we decide to prolong the DAPT beyond 12 months is the complex PCI. As you know, if a patient is treated for multivessel disease, especially with stent implantation on the left main, or with implantation of more than 3 stents of longer stent, this is considered as a complex PCI. And the complex PCI, together with all these other risk factors, is considered an element important for high ischemic risk. And this study from Gennaro Giustino demonstrated that DAPT prolongation have an important benefit in patients treated with complex PCI as compared with patients that were not treated with the complex PCI. But if we decide to treat our patients with the long DAPT, are there concerns? Of course, the answer is yes, because as you know, we are treating patients with drugs against platelet aggregation. And as you know, platelets are very important for normal hemostasis. So in an attempt to help our patients against thrombosis, that is to say, again, ischemic risk with DAPT, the risk is to have another side of the medal that is bleeding. And as you know, all the drugs that we can use to fight against platelet aggregation, aspirin, clopidogrel, prasugrel, or ticagrelor, as main side effects bleeding disorders. So we have to balance between the ischemic and the bleeding risk for these patients. The study that I show you a few slides before demonstrated that aspirin alone gave a better outcome considering the side of bleeding as compared with the ischemic events. And the Italian Society of Cardiology, and specifically the Working Group on Thrombosis, including me, in this consensus document considered bleeding as a concern about DAPT prolongation beyond 1 year. And so we have to balance, as you know, between the risk of bleeding and of new ischemic event. And the current guidelines of the European Society of Cardiology, as well as of the American College of Cardiology and of the American Heart Association, have considered bleeding an enemy against DAPT. In fact, they consider that patients with ACS who have tolerated DAPT without the bleeding complication during the first year can be considered eligible to continue for 12 beyond 12 months. And so we have a messy situation, ischemic and bleeding disc. How can we solve this messy situation? Maybe we can consider the risk score. The first one, the score that we have to consider at this time bomb is not the precise score that we have to use at the time of coronary stenting, that is during the hospitalization of the patient. But we have to use the DAPT score, that a score that was used in the DAPT study with prasugrel, and that was permit to evaluate the patient after 12 months of uneventful DAPT. However, we know that current guidelines have a level of recommendation very low for DAPT score because their value in improving patient outcome remains unclear because they have not been used in randomized controlled trials. And in fact, we have to consider that the history, the clinical history of the patients is dynamic, and it's not static. And my personal point of view is that we have to continue to do the clinician in order, because if we consider only the risk score, we have a dichotomic yes or not risk stratification of the patient. And consequently, we have a dichotomic therapeutic approach. My point of view is that clinical judgment permits to have a continuous risk stratification of our patients. And so this kind of approach, I believe that permit to have a better tailoring of therapy for our patients. And to reach this goal, our study group considered this acronym MADRE that include M as a multivessel disease, A as age older than 65 years, D as diabetes, R as a renal impairment, E as event recurrence, to identify clinically those patients that can have benefit from draft prolongation. And so I want to conclude with an how to do after 12 months. First of all, we have to consider the clinical approach to the patients. Then we have some question to do. Well-tolerated DAPT during previous 12 months, bleeding complication, coagulation disease, anemia, thrombocytopenia, waiting for surgery. Sometimes we have to wait before surgery because we have some concerns about stopped DAPT for the high risk of the patients. It is the patient, as the patient's new onset atrial fibrillation, because as you know, if the patient has to start with oral anticoagulation, DAPT is not considered. And finally, low weight or female, gender or weight are other two concerns to prolong the DAPT in our patient. So I wanted to avoid this situation in which we are try to calculate the risk score with a calculator, because I believe that we have to continue to evaluate our patient as medical doctor. The patient is the spot, is the hot topic of our work every day, especially in this dangerous period of our life for COVID situation. This is my last slide. Thank you for your attention.
Thank you very much, dear Plinio Cirillo. And yes, I think this is really very interesting data. And those clinical thoughts you provided definitely is a good food for thought. And definitely we are now equipped by this knowledge when we make real clinical decision in the real practice. And now we are moving to the final presentation of this session. And this is Dr. Surgaliev, who is also representing Kazakh Medical University, and he's the leader of the chair #1. And he is a very famous Kazakhstan specialist. His presentation, the importance of primary and secondary prolonged prevention of the venous thrombosis in GP practice. Can you hear us? Yes, we can hear you. Positive, right. And after this presentation, we are expecting Q&A. So good afternoon, dear colleagues. First of all, I would like to thank organizers. And I would like to thank my dearest friend, Professor Plinio, for being with us, for finding time to be here, for brilliant presentation, and for this great opportunity that Eurasian Association of Therapists allows us to have such close discussion with my friends. And again, many thanks to the Italian Anti-Thrombotic Society, ECC, Marco Catania, Plinio, and Franco Piavello, and other colleagues, because when we're preparing protocols, when we prepared protocols in Kazakhstan for anticoagulant part of COVID, definitely we were guided by our Italian friends and colleagues. And Professor Plinio, we wrote such a good article in Kazakhstan about macro and micro thrombosis in patients with COVID. I think this is very good. That's very good beginning, and hope it's not the end. In this slide, distinguished colleagues, I try to show the current paradigm, that means risks of thrombotic events in severe therapeutic patients. Well, I was just taking from the realities from the available publications. And if we speak about the problem of thrombosis development in severe therapeutic patients, so by now it looks like this. That means all severe patients, so that means medical patients with severe heart failure or severe respiratory diseases or something else, risk of thrombosis is actually for 90 days at least. And if this is 90 days, we can split these 90 days into three big periods. First is acute period, then hospitalization period, 6 to 14 days. Of course, it used to be like that, but now it's not the example, because in Europe and United States it could be different, probably in Kazakhstan and in Russia. We're also moving that way, but yet now it's a maximum period of hospitalization of the patient. So it's about seven to 8, maybe 10 days, but not 14 days, and not anymore. The second period, it's like period after the discharge from the hospital, 45 days. And I would like to talk about it because here there are lots of thrombotic complications. 80% the development of thromboembolic complications happen within 45 days after the discharge of the patient from the hospital. And the third period, it's a chronic period of therapeutical disease, and it is shown here in my slide, like 40 days. And in these 40 days, definitely the risk of thrombosis is still persisting, but it's less than it was in the previous period of first 45 days. We know that low molecular heparin and fondaparinux up to 14 days reduces the risk of thromboembolic complications by 50–60%. But as I said before, now we almost don't have it. Right now, patients are hospitalized like 3–5 days, and that existing paradigm of venous thrombosis prevention is probably not quite acceptable anymore. And with time, definitely it will be changing, and it will be reducing. We will shorten the number of days of hospitalization. Hospitalization would be shortened. If we look at the venous thrombosis statistics, so during the hospitalization in the hospital, so the average rate of thrombosis is from 10 to 26%. Then right after the discharge, the rate is 60%, and within 45 days, as I said before, 80%. So can you imagine that? And if you look at the data on prevention, so I can tell you that less than 4% of the patients are getting prevention after the discharge. And definitely, I would like to say that in this period, the risks of thromboembolic complications, mainly related to what? With the severity of the stroke, chronic heart failure, chronic obstructive pulmonary disease, and possibly rheumatic and other conditions. And at the same time, we need to say that in the world, there are not many hospitals that assess the risk of thrombosis when the patients are hospitalized. That's why I want to say the following. So I want to say that at the outpatient level, risks of venous thrombosis is underestimated. And specifically, this is a risk of thrombosis, which is mainly related to the specific risk factors, severity of the disease, and definitely condition of the patient. According to the data, it was said that the plateau in the thrombosis risk development, it reaches day 50–60 from the moment of index event, and then the patients definitely, it is preserved in those patients who are bed-driven. And in the latest guidelines, they're saying the following. We have to assess the risk of venous thrombosis using the model of risk assessment during the hospitalization of the patients and before the discharge, And this is the recent data. This is the latest data. So these are the results of using new oral anticoagulants. Well, the first was definitely matrixaban, but now, quite recently, rivaroxaban was approved in the dose of 10 milligram for the prevention of venous thromboembolias in that very severe medical patients. And the grounds, the basis to include NOACs peros into the guidelines are the results of the pivotal studies. So first is Magellan study with rivaroxaban and enoxaparin, then ADOPT with apixaban, then APIX with betrixaban, and Mariner with rivaroxaban. And duration of NOACs was about 30-35 days. But at the same time, distinguished colleagues, please appreciate the venous thrombosis rate was much better in the group of patients that they were taking new oral anticoagulants versus low molecular heparins. But if you look at the bleeding rates, so we can appreciate that the risk of bleed development in the group of patients that were taking new oral anticoagulants were definitely higher. And this is Mariner study. The risk of bleeds with betrixaban with the same dose of rivaroxaban appear to be lower. And why it happens like this? In Mariner, investigators use totally different model of thrombotic risk assessment. It was called Improve DD. Improve DD, they simply added and they changed existing risk scale. They added and they actually looked at the patients that have doubled D dimer, higher twice than the upper limit of norm. And they excluded a group of patients that have pretty high risk of bleed. So in the phenotypes of these patients, and these are new oral anticoagulants, NOACs. And after that, the investigators did the following. They made sub-analysis so this is a scale assessment of risk of bleed, and they excluded those patients that had higher risk of bleeds. Finally, they got the following picture. As I said before, in the Magellan, this is rivaroxaban versus standard dose of low molecular heparins. It actually demonstrated this type of thromboembolic complications, but the risk was higher. But when they excluded patients with high risks of bleed, there was no big difference. And that was the reason of the approval of rivaroxaban 10 milligram for the prevention of thromboembolic complications in medical patients. And mainly, we speak about primary prevention here. But let's try to look at the patients who already have thromboembolic complication in the medical history. We know that currently there are so-called 3 phases in the treatment of venous thrombosis. We see the initiation, that is about from 5 to 21 days. And in this part, they use normally parenteral anticoagulants, and there are 2 new oral anticoagulants. This is rivaroxaban and apixaban. Then maintenance doses, and I have to say, dear colleagues, in the stage of initiation, we don't have NOACs. We don't have 2 NOACs here, no dabigatran and edoxaban. Next strategy is maintenance. Maintenance strategy with a minimal period of treatment. That means thromboembolic complications, 3 months. And in this part of maintenance here, we have 2 new NOACs, which is the dabigatran and edoxaban. So in the strategy of switch, when you switch patient, and they start from low molecular heparins first, or maybe fendoporinox, and then from after day 21, we switch patients to the NOACs mentioned in the middle of the scheme, or we just continue rivaroxaban or apixaban if they administered before. But please appreciate doses a little bit different. And now in the new guidelines, we have absolutely new era, so-called prolonged, when we don't know when, difficult to identify when to stop anticoagulant treatments. First of all, these are the patients that probably have high risks, and at the same time, the factors that facilitate development of venous thrombosis are not yet identified there, so-called not provoked thrombosis. And this is the meta-analysis of 18 studies where more than 7,000 patients were included. Here we see that if we stop anticoagulant treatment in the group of patients with so-called not provoked thrombosis, when the factors are not identified, then you can appreciate it here. Within the first 2 years, the rate of venous thrombosis relapse would be 16%, and up to 5 years, it would be 15%, and within 10 years, that would be 36%. So what I want to say here, first of all, those who need long-term prevention after the previous thrombosis, definitely these are patients with non-identified risk factors for venous thrombosis. So what can we find in the European guidelines for pulmonary artery thromboembolic treatment? So European Society of Cardiologists, they split all the patients into different risk stratas on the venous thrombosis. So low risk, interim risk, and high risk. And you can appreciate this chart here. What is low risk? These are those patients who within short period of thrombosis, they're high risk. So these are those patients, orthopedic patients or surgical major surgeries. So they have massive risk factors at the moment of particular medical interventions. So this is traumatology, fractures, orthopedic surgeries, etc., etc. And please appreciate here, in a short period, they belong to patients of a very high risk. That is why these patients mainly should get this prevention of thromboembolic complications during surgeries. Next group of the patients are the interim patients of the interim group. So please appreciate here, this is the interim, and here at the bottom we have a phrase, interim group contains patients where risk factors of thrombosis are not identified. So this is the category of a patient, pretty high risk in terms of relapse. And here are high-risk patients with active oncological disease and with one episode of the previous venous thrombosis, with absence of reversible risk factors, and also patients with antiphospholipid syndrome. We have to wrap up. Yes, for that, there are different models, which I already covered before, and this is gender models, and for females, this is a HER2 model, which is validated as well. So in these cases, when we identify that we need to administer long-term anticoagulant treatment, there is always a challenge that was already mentioned by Professor Plinio. That means risk of thrombosis. Risk of bleed. So we should have a balanced approach. And in this study, it has been mentioned that patients with pulmonary artery thromboembolia, for about 10 days with the use of anticoagulants, in 33 we see fatal thromboembolia, and in 34 we see fatal bleed. And 360 days later, 1 year later, we have 107 cases bleeds. And in these cases, surely, we are between Scylla and Charybda. We are between thrombosis and the bleeds. And here we are between these two dangers, between hammer and nail. The situation changed with new oral anticoagulants and all the studies shown here. You can appreciate that If you look at the Bigatron study, so here you have high risks of bleeds. From NOACs, the lower risk of bleeds is rivaroxaban, 10 milligram, apixaban, and definitely the use of other treatments, Solodoxid and others. And let me show this curve. This is Einstein choice. So this is Einstein choice study where they compared aspirin. This is the only study, by the way, with NOACs, when NOAC was compared to aspirin. And it appeared to be that NOAC rivaroxaban was much more efficacious and much safer venous thrombosis prevention in patients with venous thrombosis versus aspirin. And definitely we need to identify risk scales. Well, these scales are known for you, and all that is presented in the European guidelines. So minimal period of treatment, 3 months, as it was said before. If patients have antiphospholipid syndrome, then these patients should get vitamin K antagonists. And in this group of patients, the use of new oral anticoagulants does not prevent development of thrombosis, especially in patients with triple positive antiphospholipid syndrome. If patient needs long-term prevention, that mainly this is a priority, NOACs priority, and here it is, apixaban 2.5, rivaroxaban 10 milligram, and after 6 months. And if the patient refuses or there is intolerance to NOACs, then possibly we can use Solodoxide, aspirin in this category of patients. And this is my final slide. And this is the reflection of our strategy. So drugs mentioned here. And I'm showing you my beautiful city. And Plinio, please welcome to us. This is Almata. This is Chemgansky Canyon. And let me show you this one. This is cable car. So we live all in Almaty, all three of us who speak today from Kazakhstan, we all live in Almaty. We have everything, you know, we have everything. We have beautiful mountains, we have beautiful canyons, we have great lakes, and not far from us, we can appreciate singing barhans. So welcome to Kazakhstan, welcome to visit our motherland, and we would be happy to talk, to discuss, to share experience, to cover all the topics that were presented at this symposium today. Thank you very much. Thank you very much, Professor Surgaliev. So many interesting data. And definitely, this is a very good food for thought. So we are making recordings, so we will be able to listen to the presentations again. And we go back to our webcast studio to St. Petersburg. And let us move to the Q&A session. Well, unfortunately, actually, we already depleted our time, and we cannot discuss many questions. And let me ask only one question. And in fact, this question already was asked many times. So let me ask it to our distinguished speaker, our expert, Professor Plinio Cirillo. So the question is to you. The question is the following. The question about anti-platelet treatment for COVID-19. So we know that any virus can influence vascular wall, increasing its permeability. How high is the risk of bleed if we administer dual antiplatelet treatment after ACS in patients positive for COVID-19? And if we still administer the treatment, what should be the optimal duration of this treatment of patients with ACS, with COVID and without COVID? So in other words, should we stop or should we change antiplatelet treatment in patients that is infected by COVID? Thank you very much. The floor is yours. You're welcome.
Oh, thank you for this very, very interesting question. You know, the study about coagulation and thrombosis in COVID have shown that platelets are only partially involved in this phenomenon because the coagulation pathway is involved. As you know, in patients with this kind of disease or infection from COVID virus, platelets seems not to be actively involved. Sometimes these patients have thrombocytopenia, and not elevated number of platelets. So my point of view is that if the patient need to be treated with anticoagulants, that is low molecular weight heparin, you have not to stop DAPT because you have to fight against the stent thrombosis or however a disease that is the ACS in which platelets are actively involved. Another point of view is when you have to treat patient as a patient with a atrial fibrillation with oral anticoagulation. In this case, I believe that platelets should be restored in their activity, and so you can stop DAPT after not less 1 month after stent implantation. But however, at this time, we do not have a study and data about this particular situation. Anyway, I want to take a take-home message. I believe that DAPT should be continued in those patients treated with low molecular weight heparin and not should be stopped in those patients treated with the oral anticoagulation, such as patients with the atrial fibrillation, because we have to avoid that the patients treated for COVID had a new ischemic event, a new acute myocardial infarction, especially after stent implantation.
Thank you, dear Plinier. Thank you very much for your position, and thank you very much for your very comprehensive response. Unfortunately, dear colleagues, we are very much behind the schedule, and the next session is about to start within 3 minutes in this hall. Although we received 1 ton of questions, but we cannot ask them. So many thanks to all our dedicated speakers. We witnessed a very interesting symposium that briefly can be called How to Find this very fine balance between Scylla and Charybda, between the thrombosis and bleed, and to stay alive, and to get benefit for the patient, and to reduce cardiovascular risks. And I believe that the second part of the symposium, which was covering different aspects and nuances of clinical portrait of the patients with MI in the modern times in Kazakhstan Republic, also caused big interest, because I believe that mainly these risk factors and these clinical characteristics of our patients are authentic to our average population. With that, let me announce the break, and let's meet here in 3:45 Moscow time in fact, 13 minutes. Enjoy your break, and thank you very much. Thank you very much for very interesting symposium. Have a good day, and goodbye.
итог, уважаемые коллеги,
Distinguished colleagues, all those who are back with us, congratulations, because we are all back and we are again discussing the relevant issues of internal diseases. And now it's my greatest pleasure to announce a very interesting symposium, which is called Relevant Issues of Digestive Organs in Comorbid Cardiology Patients. And the experts that are here with us today that will participate and carry out this symposium, these are leading experts in this therapeutic area. And I believe it's very important that we are going to consider the portrait of comorbid patients with gastroenterological issues. And let me open this symposium to the chair of propedeutics, dietology and diabetology, Northwest Medical University, named after Mechnikov, chief therapist of the Northwest Federal Region of Russia, Professor Bakulin Igor. The topic of the presentation he is going to make is extremely interesting. And I believe that it's seen in the practice of any internist, acid-dependent diseases as multidisciplinary challenge. The floor is yours. Vladimir, we can hear and we can see you perfectly. Distinguished colleagues, after this representation, I'm very pleased to start. I want to fly high into the skies and to speak more and more about the acid-dependent diseases. Yes, my presentation is the first one, and I start GI Symposium. And according to the last year data, our symposium had the highest ratings. So let's try, dear colleagues, don't give up, rush ahead. So 3 issues that I'm going to discuss with our colleagues, therapists and cardiologists. First is shown here, acid-dependent diseases, general positions in the treatment of therapists and cardiologists. So acid-dependent diseases, they are split into organic and functional. And we have to speak the same language here. Let's keep it once again. And in fact, this is a group of diseases where the most important pathogenetic factor is the aggressive acid production. And finally, as you can appreciate it here, we made the second representation and this dependence of these diseases on the presence or absence of Helicobacter pylori infection or its absence. So the first issue, the first thing we are talking about, just acid-dependent without Helicobacter pylori infection. So probably all of these diseases, they're very difficult to prevent or difficult to discuss all of them. So let me select one of the best examples of acid-dependent diseases, which is GERD, gastroesophageal reflux disease, through the prism of multidisciplinary approach. Today, we have the data about the prevalence of GERD in Russia, and I can confirm that, unfortunately, in our reporting forms in therapists, we still do not have this indication. That's why different publications, well, different representation, even from the very recent years, 2019, 2020, we don't have epidemiology data, but this is the publication of 2020, and this is the data we see for Russia, so highly presented this pathology. So this is very prevalent. And the second thing, we have to say from the very beginning that GERD, gastroesophageal reflux disease, is quite frequent comorbidity or associated diseases in patients with main cardiological or pulmonological diseases. Why? First, let's appreciate the specificity of pathogenesis. This is multifactorial, and we see from the very beginning that those cases when we're actively using drug treatment, but we are therapists, we're cardiologists, yes, we can actually do it with our own hands, because we can lead that the gastric content is going to the esophagus, to the lower third of esophagus. And this is how we see the symptoms which are known very well, which is heartburn and regurgitation. Also, Monreal classification shown here of clinical symptoms of GERD. And for the cardiologist, that would be also interesting to see that one of the syndrome is considered to be a so-called non-cardiac chest pain. that frequently requires differential diagnosis, but not just the cardiologists, but also pulmonologists can be actively involved. Not just the pulmonologists, but possibly other specialists. This is cough, laryngitis, BI, erosion of teeth enamel. So this is what is known for sure. But if we speak about the cough, then cough is probably the most frequent mask of GERD. And in multiple guidelines, we have even notification to the guidelines or features, very clear features of the cough associated with gastroesophageal reflux disease. So let's keep it in mind. And I think today, during this symposium, we will be able to go back to that. And finishing the story with GERB, again, we should cover the other issue, which is refractory GERB, when the drugs that we administer appear to be not effective. Well, we understand that it can be because of low compliance of the patients, possible comorbidity, not adequate regimen of dosing, etc. But still, this is what I'm showing here in circle. One of the biggest or most frequent reasons of refractory GERD are other diseases. And again, here we see a big list of diseases that we therapists and cardiologists are dealing with in real practice. The second question, and it is shown here separately, non-steroid anti-inflammatory or NSAIDs, gastropathies. And again, the questions would be overlapping with therapeutic or cardiological directions and enteropathies. So the first thing I want to start with is to show you the structure of mortality because of GI diseases. This is St. Petersburg data from 2018. I want to say that in pre-COVID area, so this structure was quite stable, So what I want to draw your attention to, I'm not talking about the liver diseases because today we will have a dedicated presentation about that. You see liver diseases, this is number one in terms of mortality in the structure of GI mortality. But please appreciate this box. About 13 and the different regions, up to 15% mortality from the ulcerative disease. Or is it true? Is it really true? And I want to say that this is actually not the essential ulcerations. These are ulcers that we very frequently refer to symptomatic one. And this is what can join us together with therapists and cardiologists. Please appreciate every second gastric ulcer related to the NSAIDs is complicated by the bleed. And this is reality. And this is actually the very frequent reason of mortality, specifically home mortality. So if we speak about definitions, this is upper GI tract, and this is chronologically with the drugs and characterized by the ulcerations or erosions. And as it was said before, it is complicated by the bleed that can also be the reason of the fatal outcomes. And I'm showing you the pictures that you all remember very well. You all know them very well. And what is important for the cardiologists, that means we frequently speak low doses of aspirin, or let's say safe doses of NSAIDs. Any truth here, or maybe myths? We have to say that the lower doses of aspirin are also a risk factor of the bleeds. We're speaking about the bleeds. And this is a risk. General oval population, this risk of bleeds is higher in those patients. Even lower doses of aspirin. Let's remember about that. If aspirin is administered for the prevention of cardiovascular system, and about different conditions as well. Very important issue and multiple publications that are actively ongoing. So this is identification of risk factors of NSAIDs gastropathies. So we can appreciate here that you see a number of risk factors with the notification and assessment scale. This is chance assessment. The age 65 plus, 4.5 times higher risk of NSAIDs gastropathias, ulcerative analysis 4 times higher, elderly age and ulcerative history 17 times higher. But here we speak about the combination of NSAIDs in high doses or simultaneous administration of several drugs, and the risk is increases 7 times or more. And Helicobacter pylori infection, that means 6 times or even more. This is a risk factor of NSAIDs gastropathias. So very briefly, I want to tell you that then there would be presentation of Natalia that will be devoted to thrombotic, anti-thrombotic treatment. So I want to say one thing. The NSAID administration in combination with different anticoagulants increases the risks of gastropathias and bleeds. So after the identification of risk, different specialties started thinking about it. And this is quite convenient if we think about multidisciplinary consensus. This is very convenient to speak about the clinical guidelines that are mentioned here. Specifically, you see 2 populations of doctors that participated here, and these are rheumatologists and gastroenterologists. Risk stratification in NSAIDs, risk is high. Risk is high if there is ulcerative history, if there is GI bleed in the medical history, and if we see the administration of lower doses of aspirin, etc., etc. All that is a high risk. Then moderate risk, elderly age, smoking, glucocorticoids, then Helicobacter infection, and low risk if this is the absence of risk factors. And if no risks, still these are minimal risk factors. And there are always risk of GI tracts. So what about these risks? What about them? With this stratification, rheumatologists and gastroenterologists made consensus. And here we mean the administration of the rational NSAIDs treatment and combined administration of the drug for the prevention of NSAIDs gastropathy, specifically proton pump inhibitors, already in the title. So if the risk is low, then any NSAIDs can be used. If the risk is moderate, then we can use any NSAIDs, but definitely in combination with proton pump inhibitors, and then with non-selective NSAIDs, specifically PPIs inhibitors, and in case of high risk. And there is definitely need of selective NSAIDs in combination with proton pump inhibitors. So let me show you what could be this algorithm in practice. So that means the main method of prevention, keeping in mind risk factors, and then the administration of NSAIDs, keeping in mind these factors, these risk factors. So additional method here, additional method of prevention is the administration of proton pump inhibitors. And the same we see in different guidelines of Russian Gastroenterology Association, the treatment of NSAIDs and PPI. It's the very best prevention. So PPI should be used for the prevention of NSAID-associated enteropathies. We have to say that this is something which is frequently lost. Very frequently, it requires some specific verification. And here we mean that it can be not just the diagnostic option, but about the need of prevention NSAIDs enteropathies, as it's shown with this guideline. So additional method of prevention from the upper GI tract gastropathies. It could be ribimipid, and the level of evidence B. What is ribimipid? And I'm pretty sure that majority of our audience definitely are aware of this drug. But now I would like to confirm that in gastroenterology, this issue is very frequently discussed. That in fact, the small intestine, large intestine, they all have 3 levels of protection. So pre-epithelial, this is the mucosa, then epithelial, this is tight contacts, tight junctions, and regeneration property, and post-epithelial level of protection, which is active blood circulation, active microcirculation. So if we talk about the current understanding, this is the evidence-based treatment at all levels of protection. So it stimulates, it works and facilitates the generation of not only epithelial cells, but also normalization of the contacts, tight junctions specifically, simulates the release of prostaglandin, and finally works at the 3rd level. That means post-epithelial protection, improving the microcirculation of the mucosa. And last but not least, I think this question can be covered also in other presentations, if we have similar questions. And I think we lost the speaker. And also therapists having direct relation to that. So please appreciate here, patients are comorbid, those patients who have atrial fibrillation, those who have some negative prognostic criteria that can be effective. As we can see, Helicobacter infection is the leading one. So 5 times risk is increased 5 times if there is Helicobacter infection. And let me say that in all the consensus, both international and Russian one, Helicobacter infection is the reason to have eradication. So today we are talking about that for the eradication we need proton pump inhibitors with the maximum acid suppression according to the Russian guidelines. As you can see, we have to prefer rameprazole and esomeprazole. But today we're still talking that not always the eradication is the effective, and that's why we need to optimize the regimens of eradication. And here we also can use additional pharmaceutical agents, ribamipid, for example, bismuth-3, calcium dicitrate, probiotics, high doses of PPIs. I think doctors of general practice, therapists and cardiologists also should be aware about that, and also about ribamipid. You see, there is a particular niche for eradication. After successful eradication, ribamipid can be used in case of inflammation and in case of atrophy because symptoms are persisting. So with this point, the drug can also find its own niche. So wrapping up, dear colleagues, we as gastroenterologists, we love to ask questions to different doctors. Do you know your H. pylori status? And today our conference, our formats maybe is not the best and we don't always get the answer. But here I would like to refer to our own study, to our results of projects of infectioning rates of Helicobacter among the doctors. Well, due to clear reasons, representation of St. Petersburg doctors is the biggest one because this is our local survey. But we know that right now our audience is really very representative. Very many doctors from different cities, not only from our country. And we can try it on. So about 60%, of the doctors, they don't perform endoscopy. They don't refer to the endoscopy care. And speaking about other doctors, these are therapists and gastroenterologists, as you can appreciate, very frequently infected by Helicobacter infection. So with that, we can sum up. But once again, let's make this message, Gert, So first place in prevalence among acid-dependent diseases, and very frequently it's comorbid condition in patients with cardiological and pulmonological profile. Then treatment approaches in NSAIDs gastropathies, first of all, include risk assessment, then rational administration of NSAIDs and using of PPIs. And last but not least, don't forget about Helicobacter pylori infection, which is additional risk factor, both for the development of NSAIDs gastropathy and also for the bleeds in this context. So many thanks for your attention. Thank you very much for a very interesting presentation. And definitely each doctor most probably took a very practical lesson from your presentation, and these are approaches that they're definitely going to use in the future. And if we refer to the last message and to the last presentation you shared here, I think only today we learned how to assess HP infection when we faced other infection. And we continue our symposium. And the next presentation would be made by Professor Natalia Bakulina, who is the lead of clinical pharmacology chair of Northwest State Medical University, who will make a presentation on the prevention of GI injuries with antithrombotic treatment. And I think there is big interest to this presentation because even the previous session we were discussing the factors of aggression, but now we have to talk about the factors of protection, about the measures of prevention. Natalia, can you hear us? Good afternoon. Thank you very much, Vladimir. I'm very happy to welcome all of you who just joined our symposium. But my presentation would be logical continuation of Igor's presentation. Yes, today we will talk about heterogenic things, what we can do. What are the risks in patients with antithrombotic treatment, those who are indicated, but still those who are carrying risks? Let's talk how safe antithrombotic treatments are. So actually, what is carrying biggest risk? Well, definitely dual and triple anti-thrombotic treatment, and cardiologists, they know that very well, and they try to reduce the periods of dual and triple antithrombotic treatment. What is on the second rate? This is definitely acetylsalicylic acid, then a lower ranking clopidogrel, ticagrelor, and then porks and warfarin. So what from them is mainly damaging the mucosa, warfarin or porks? So in the studies, we may think that this is warfarin, but in observational projects, it appears to be that still new drugs or NOACs, direct anticoagulants, do have some advantages. We all talk about the risks of iatrogenia, and I'm pleased to look at the guidelines that were designed and published in September 2020. And European Society of Cardiologists that we need multidisciplinary approach to the patient management. Please appreciate how many specialties cardiologists to be needed to involve to patient management. But where is gastroenterologist? Oh, it's a pity that gastroenterology seems to be forgotten, but on the other hand, we do have something to talk about later on. So let's talk about the prevention of GI bleeds. What scales are offered in the European guidelines? What can we use here? So they compared two prognostic scales of risks of bleeds, ABC, bleeding risk score, and Hasbled. So it appeared to be that although ABC is more convenient to use, but still there is more prognostic value for the detailed Hasbled score, which is in the 3 points, is telling us, alarm, dear colleagues. These are the patients of a special risk of bleeds. So these are the scales which are used for the assessment of risk of bleeds, but never ever we should hide behind the scales to avoid administering anticoagulant treatments. So what else can we do when we get 3 or more scores by Hasbled? We have to make maximum effort to modify risk factors. And here you see updated list of bleeding risks. And here you see we do have potential to influence. We need to control arterial blood pressure. We have to control simultaneous use of drugs to reduce the risk of control alcohol intake, compliance, extremal hobbies. Oh, by the way, we never had it before. Bridging treatment by heparins, more precise control of INR for the patients who are getting this treatment, and then correct selection of anticoagulants, mainly correct selection of doses, depending on the renal function, depending on the age, depending on the weight, depending on what drug was selected. Besides, in the potentially modified risk factors, we have another definition as a fragile patient who has high risk of falls, and it also facilitates the risk of bleeds, anemia, reduced platelet level, renal failure, and finally, antagonists of vitamin K. So you see the doctor is smiling because he is happy and there is a potential to help the patient. And this part is pretty sad because here nothing can be done with these non-modifiable risk factors. This is the age of patients, renal replacement therapy. What are the news? Genetic risk factors. Now they are taking into consideration plus polymorphism by cytochrome P, which is also non-modifiable and unfavorable risk factor. Besides biomarkers, we have Willebrand factor here, and unfortunately we cannot influence that, but we can take into account when we range these risks. And now I would like to provide practical algorithms of Eurasian Association of Therapists that has also proved that it is very important to minimize clinically significant drug-drug interactions. The use of alcohol should be minimized, and also some other factors that are shown here. All these factors would be discussed in detail, including Helicobacter pylori infection. So the first thing, drug-drug interactions. Back in 2018, recommendations, European Society of Arrhythmologists, is telling us that the patients that are taking PORCs, these are patients for them, we need regular reconsideration of drug-drug interaction because these are polymorbid patients. And we are aware very clearly that there is class effect for PORCs and there are specific drugs and effects, and everything depends on the metabolism. For example, for the biggest one mainly, that would be a P-glycoprotein transporter. Then for apixaban, rivaroxaban, for all xabans here, mainly we take into account the level of cytochrome P450, and definitely there is chart, and Eurasian Association of Therapists created very important charts based upon the instructions for the drugs that should not be forgotten. But every time we should open and we should check what should or what cannot be mixed in between. So we are correcting factors provoking erosion of the mucosa and also the gastric and the gut, and mainly we're speaking about NSAIDs gastropathies. So I'm skipping this because it has already been covered in detail, plus infection of Helicobacter pylori. So the main task here in the patients with the risk of thrombosis, the main task is to preserve anticoagulants and to reduce the risk of bleeds. So here there is a suggestion that selective NSAIDs, let's say COX-2, selective inhibitors, less damaging for the mucosa. Yes, on the one hand, yes, but none of the patients could be 100% protected with NSAIDs administration. And here you see the clinical case. So this is the patient who had just 2 doses of atericoxib, came with pain and complaints the dark stool, and then ulceration was found. So we have to be very cautious for NSAIDs, especially for the patients that are in the risk area. So if patient is administered NSAID, we have to understand that the risk is always there. Risk of the bleed, risk of the damage. So what do we need to do? We have to examine patient for Helicobacter pylori and to have eradication of that. That is a surprising study which was published quite recently. Patients were examined before the administration of anticoagulants. Then 3 months, these patients, where there was no gastric damaging, they were taking warfarin and 3 porks, dabigatran, rivaroxaban, or apixaban. And then 3 months later, these patients were checked. And you see that the damage can happen at any of the anticoagulants. But very important conclusions here. 3 months later, there is no clear difference in the rate of clinical and endoscopically significant bleeds. That is why we should all remember this, this quarreling. You are the better, we are the better, they are the better, but there are no head-to-head comparisons. But based upon this data, we can make a very important conclusion, practically important conclusion, that we need to perform Helicobacter pylori eradication because H. pylori is a factor of risk of GI bleeds for any anticoagulant, and it has been proved by the study. So, and here PPIs. PPIs are very protective. So very important conclusion. Anticoagulants by themselves normally not damaging the mucosa, but they can facilitate the bleeding and they have a so-called reflective effect. If patient has erosion, if there is cancer, so that would be a problem here. That means the damage and the bleed will definitely happen in this location, in this site. So erosive gastritis, erosions, colitis, ulcerative disease, symptomatic ulcers, this is NSAIDs, gastropathies, neuroendocrinic tumor, GERD with esophagitis, portal hypertension, the syndrome of antral angiectasia, cancer, esophagus, gastric, so inflammatory conditions. So all that with NSAIDs could worsen dramatically and cause a bleed. And I would like to draw the attention of cardiologists to wonderful opportunity to use express methods for the diagnosis of bleeds, occult bleeds. So this is immunoassay that can allow us to find hemoglobin and hemoglobin linked to haptoglobin. That means to diagnose the upper compartment bleed and lower compartment bleeds as well. And last but not least, this is the final accord in treatment. What are the news? What are the news here? And we have the bigatran, which is in fact specific treatment to neutralize the bigatran, which is idarucizumab. But and then registration of studies are ongoing for andexanet alpha that would be specifically blocking the effect of xabans. So idarucizumab, this is humanized fragment of monoclonal antibodies, the bigatran. So do we have to use this drug frequently? When the registrational studies were ongoing, they even could not recruit the patients to include into the trial because there are few bleeds, really life-threatening bleeds where the idarucizumab can be indicated. So how can we protect the mucosa? About 30% of the patients, according to the very big database, so 120,000 patients are getting PPIs inhibitors. So we have a big choice among PPI inhibitors. So we see that there are new drugs with a big modified prolonged effect. There are stereoisomers, there are racemic mixtures. So this is left and right rotating. Pantoprazole, rabeprazole. So these are options. So they can meet clopidogrel. They don't have drug-drug interaction with clopidogrel. And omeprazole and esomeprazole, that's another story. And by the way, cardiologists do know about that very well, because in the label, we clearly know, and that was FDA requirement to change the label and to write here about the risk of drug-drug interactions of omeprazole, esomeprazole, and clopidogrel. Wrapping up, the treatment of erosions. First, correction of aggressive factors. Definitely H2 blockers are already in the past. These are PPIs, only PPIs, alginates, anticides as emergency. correction of protection factors, cytoprotectors. For us now, we have new cytoprotector, alphazox, for the protection of the gastric mucosa, and then the drugs that already have very good reputation. This is also the zoxifolic acid and ribamipid. And the basis is correct eradication of Helicobacter pylori, timely eradication, which allows to reduce in many folds the risks of GI bleeds. So in case of GI bleed risk factors, we correct modifiable risk factors and we perform eradication. And then we administer PPIs and ribamipid for the prevention of NSAID-associated gastroenteropathy. Thank you very much for your attention. Thank you very much, Natalia. Yes, very clear, very concrete, and yeah, very obvious presentation. And I believe that every internist who is facing this need to cover, if I can use this term, cover GI tract with antithrombotic treatment, would do it exactly the same. First to stratify, then to carry out the eradication, and etc. Dear colleagues, we could continue now, and I'm happy to give the floor to the next speaker in our session. And this is Ekaterina Skazevaeva, who is Associate Professor of Gastroenterology and Dietology Chair of Northwest Medical University, named after Mechnikov. And we will appreciate a very important presentation, cytolytic syndrome in the GP practice, masterclass of differential diagnosis. And I think any of the specialists faced once this need to interpret cytolytic syndrome when you see those changes in the biochemistry blood test. And Ekaterina, hope you're with us. Microphone. We cannot hear you. We can see you, we can see your presentation, but we cannot hear you. Please unmute yourself. Can you hear me now? Yes. The floor is yours. Well, thank you very much. Distinguished colleagues, good afternoon. So our presentation would be devoted to the cytolytic syndrome, which is very frequently seen in the practice of different specialists and differential diagnosis of this syndrome. So what is cytolysis syndrome? This is laboratory syndrome, and markers of that is the increased level of ALT and AST. And so these enzymes are seen in hepatocytes. This is statazole, hepatocytes and mitochondria. And also these enzymes are seen not only in the liver cells, and they confirm the damage of the liver cells, but also seen in the other organs, which means the damage of other organs, and that is one cytolysis syndrome. It is not just the syndrome which is characterizing liver damage. Depending on the transaminases, we identify minimal syndrome of cytolysis, less than 5 norm, moderate from 5 to 10, and severe cytolysis, higher than 10 norm. And I want to draw your attention immediately. So when we identify in the patient cytolysis syndrome, it's reasonable to examine cholestatic markers, which is creatinine phosphatase and gamma-glutamine transferase, and the cholestatic markers examination can make it easier for us to make differential search and to move us correctly and to facilitate the diagnostic periods for our patients. And also, we have to pay attention to the coefficient. This is the levels of AST and ALT in the patients where cytolysis is related to the high probability of extra hepatic reasons. So this ratio is normally increased, but totally opposite in the damage, acute hepatitis, high activities, autoimmune hepatitis, ischemic liver injury. This index normally reduces. So when we see the isolated increase of AST or unproportional increase of AST versus ALT, it should be a hint to us that most important reason of cytolysis is extrahepatic. It can be MI, myocarditis, muscle injury, myositis, muscle dystrophy, thromboembolia of pulmonary artery, acute pancreatitis. So with these diseases, cytolysis syndrome can be seen, but it's not the leading one, and this is not the diagnostic criteria. And there are other markers that actually help us to make the diagnosis. And today, for our doctors, GPs, and cardiologists, I want to speak about the main reasons of cytolysis in case of liver diseases, because unfortunately these patients are not always come to gastroenterologists and hepatologists, and they go with the time for timely treatment would be there. So viral hepatitis. So we cannot put equal HBC antigen, absence of hepatitis C, and to exclude viral hepatitis. So there are lots of serological markers of viral hepatitis in the acute period and also chronic hepatitis. And when we examine the patient, so we need to use all these markers to exclude viral hepatitis, and including PCR or RNA or DNA of hepatitis viruses. And only after the complete examination we could say, yes, no viral hepatitis here. The next situation is NASH, non-alcoholic liver disease. There are more and more patients in the population. Actually, it's asymptomatic, no pathognomic clinical features, and frequently it's associated with obesity and diabetes type 2. We could see some dyslipidemic changes, increased level of glucose. In these patients, we can see increase of cholestatic markers, so we can see the severity of NASH or non-alcoholic liver disease. We can look at steatotic grade. So most frequently we use ultrasound, and also we see changes in MRI and CT of the liver, although the golden standard is still liver biopsy if we put diagnosis of non-alcoholic steatosis or steatohepatitis. Now, autoimmune liver diseases that normally have moderate or severe cytolysis, and this is autoimmune hepatitis, which is characterized heterogeneity of clinical manifestation, increased level of immunoglobulin G or level of gamma globulins. So this is quite typical to see specific autoantibodies, and what is a must here is a liver biopsy for the verification of the diagnosis, as the diagnosis of autoimmune hepatitis is clinical morphological diagnosis. Also, in the clinical practice, we frequently see overlap syndromes of autoimmune hepatitis and cholestatic liver diseases. So in this case, it is clearly to see the increased level of cholestatic markers. And also for the verification of the diagnosis, we should perform liver biopsy. That is why to the patients that do have cytolysis, we should immediately examine them for the markers of cholestatic syndrome. And this is the status of cholestatic markers, again moves us away from the diagnosis, and for many years the patients have unclarified cytolysis. Now, NASH, non-alcoholic steatohepatitis. We have to pay attention to the British coefficient. Normally, it's higher than 2. In the significant changes, more than 3. That means increased is typical for the liver involvement from alcohol-associated disease. So why do they have a relatively low level of ALT? Those who overuse alcohol. So this is depletion of B6, and in this case, we see deficiency of this vitamin. Also, in patients, when they use alcohol, they develop mitochondrial damage, and also there is a release of mitochondrial IST. In favor of alcoholic liver disease, we see the overuse of alcohol. That means use of alcohol in the toxic doses, and also we can use surveys for the assessment of probability of NASH. And also very typical in this patient is to isolated increase of GGT related to the fact that alcohol can induce the release of this enzyme, and definitely the diagnosis of alcoholic disease. And here we need to have consultation of oncologists to verify the diagnosis. The next group of diseases are the diseases of accumulation. This is hemochromatosis. This is disorder of ion exchange. So yes, this is also asymptomatic, or the symptoms could be at the level of liver cirrhosis. There is increased iron and ferritin in the serum, transferrin reduction, and the TSAT is increased. For this pathology, we see mutations of HPA gene mutation and liver biopsy. And the patients with hemochromatosis very frequently for a long time do have cytolysis, and if there is no further examination, the diagnosis can be verified at the stage of liver cirrhosis. With Konovalov and copper exchange and its neurologic symptoms, and these patients are normally in the neurological consultation. Excretion medium copper in urine and gene ETP7B mutation and typical formation of Kaiser-Reischl rings, and you can appreciate it in the pupil, neurological and sometimes psychiatrical symptoms, and liver biopsy should be done by indication for the verification of the diagnosis. Next situation that doctors are facing, this is drug-induced liver injury. It can go via two mechanisms. First, this is direct hepatotoxic effect of the drug that depends on the dose. That can happen in any person, and normally it happens within a very short period of time after the induction of the drug treatment. And the second one is idiosyncratic. It doesn't depend on the dose. It's seen in the patients with genetic specificity. And what is typical, a long-standing period between the drug intake and the biologically active drugs, and also liver involvement. Sometimes this period is taking several months when the patient cannot recollect what he or she was taking, let's say, a few months ago. And on this slide, you see the group of drugs that are causing hepatotoxic or idiosyncratic liver injury. And all these drugs are actively used both in therapeutical practice, for example, antibiotic, which is most frequently used, amoxicillin clavulanate, can cause hepatotoxic and idiosyncratic liver injury. So acetaminophen, which is also very frequently used in the clinical practice, anti-arrhythmic treatments, statins. So that means all non-steroid anti-inflammatory treatments that in fact carry high risks for the liver of the patients. And if we talk about drug-induced liver injury, so this is the diagnosis made by exception. In order to make this diagnosis, we have to exclude all other liver diseases to have very big examination. So here quite helpful could be medical history data about the relation of this link, cytolysis syndrome with drug administration. Also, it can be used the scale of probability. This is Rocaxion scale, Rocam-Sioms. And also, we have to always identify dominating liver injury, which scenario it can be, and how drug-induced hepatitis could be here. Either it's hepatocellular or cholestatic option, or it's a mixed. And when we talk about the drug-induced liver injury, definitely the basis of treatment is discontinuation of drug treatment that is related to the changes. But unfortunately, it is not always possible. In a number of cases, the drugs are indicated by life indications. We should use maximum elimination of the drug, and as an option of treatment, we use ursodeoxycholic acid in the dose of 13-15 milligram per kilo per day. Patients with mixed or cholestatic type of drug-induced liver injury. So why do we specifically prefer ursofalk? Because this is a drug which is produced in Germany from high-quality raw materials. It reaches maximal concentration of ursodeoxycholic acid in the bile. The product had multiple clinical trials where the efficacy and safety was proved in different liver diseases associated with cytolysis syndrome. Also, there are health economy advantages, and the drug is also included into the essential drug list, which is reimbursed for our patients. Also, it has been shown in a number of trials that ursodeoxycholic acid can attenuate hepatotoxicity of multi-drug treatments, specifically in mycobacterial infections. And that's why ursodeoxycholic acid, especially in comorbid patients with multiple polypharmacia, so it can be used for the prevention of hepatotoxicity. Wrapping up, under our realities, unfortunately, We have to say that the liver is suffering from SARS-CoV-2 as well. And in case of COVID infections, there are several mechanisms influencing liver. This is direct cytopathic due to the binding of ACE2 inhibitors. And this infection increases expression of these receptors in cholangiocytes and hepatocytes. Also, liver is suffering because of cytokine storm due to the systemic inflammatory response in this infection. And last but not least, drug-induced liver injury, which is frequently seen because those antiviral treatments that are used for the treatment do have hepatotoxic potential, and sometimes non-systemic administration of antibiotics and non-steroid anti-inflammatory treatments, both doctors and patients themselves, is also introducing some contribution into the drug-induced liver injuries. And in patients with COVID-19 infection, up to 53% of the patients do have changes in ALT and AST. Also, cholestatic markers are increased, and it has been proved that the liver injury in majority of the cases is correlating with the severity of COVID-19 and is a predictor of unfavorable outcome of this infection. And it is very well known that the patients with chronic liver diseases is a risk group for severe infection, including patients with non-alcoholic liver disease. That is why ursodeoxycholic acid is one of the options to prevent development of complications from the liver due to the cytoprotective. And here we have separate data that due to the immunomodulating anti-inflammatory effect, ursodeoxycholic acid can protect the liver at the level of cytokine storm. And that is why this drug can effectively be used in patients with the treatment of multimorbid conditions. And wrapping up, just a short case. So this is a patient that came to us in September 2020. So in 1997, she was gallbladder disease, so cholecystectomy was performed, and then a few months later, she had minimal syndrome of cytolysis, and she lived with this syndrome. Well, periodically she passed the test. This cytolysis syndrome was confirmed, and it was related to the fact that, yes, bile duct is removed. This is a result of the surgery, nothing to do. In 2010, the patient really had pigmentation on the abdominal skin. She also referred to consultations many times, but the reason was not found. And in September 2020, she comes to us to the consultation. So we see markers of cholestasis that appear to be increased in the patients because there is also cholestatic syndrome, cytolysis syndrome. So patient is examined, and there is serology, and we identify specific autoantibodies, which are typical for the primary biliary cholangitis. Our time, yes. So unfortunately, under examination of the patients, and you see time is lost for the effective treatment and the diagnosis. When we examine the patients, we normally make the diagnosis of non-verified hepatitis, and only when we perform to all stages of diagnosis, we can make the diagnosis of cryptogenic hepatitis, or we make the new diagnosis. Thank you very much for your attention. Thank you very much, Ekaterina, for your very deep and comprehensive presentation. Yes, we are actually equipped with modern understanding on differential diagnosis of cytolytic syndrome. And again, many thanks for very detailed explanation of the story of liver injury for the COVID-19, because the next presentation, I believe, is also very relevant, because it will be devoted to the issues of AAD, antibiotic-associated diarrhea, in the real practice. And as we know, this is really serious and frequently seen challenge. And this presentation will be made by Elena Lutayenko. She is also representative of the Medical School of the Northwest Medical University. She is Associate Professor of Clinical Pharmacology Chair and Nephrology. Can you hear us? Are you with us? Yes, thank you very much, Vladimir. I'm here. I am with you. Good evening. Good evening, distinguished colleagues. So, antibiotic-associated diarrhea in GP. What is in the focus of discussion? Clostridium difficile and the prevention of antibiotic-associated diarrhea. Comorbidity. Well, so many things in this word. And the problem of comorbidity is very relevant. So today, we'll leave this conference So by definition, in the clinical guidelines, and Igor and Natalia, what is the definition of comorbidity? It's a combination in one patient to two or more chronic diseases. This they sometimes and in the literature, you can see the synonyms of comorbidity. This is polymorbidity, this is multimorbidity, multifactorial disease. So these are different terms, but most frequently we speak about comorbidity or polymorbidity. So it's very well known that with time, patients do have increased number of comorbidities, and this is how there are more and more comorbid patients. And in the analysis of the medical histories of those who were hospitalized, Professor Verskin is giving us the following statistics. 78.6% of the patients are comorbid. What are the nosologies included comorbid pathologies? So these are cardiovascular diseases, specifically arterial hypertension, which is about 80%, ischemic heart disease, 79%, also urinary tract infections and respiratory diseases. What are the reasons of comorbidities? This is anatomical closeness of damaged organs, common pathogenetic mechanism of several diseases. This is a time-related link between the diseases, and one disease as a complication of the other. The problem of iatrogenic comorbidity is also quite relevant for us, because iatrogenic comorbidity is seen in the negative effect, or when there is long-term medical treatment that leads to the adverse events or complications that later on become independent indication. The example of iatrogenic comorbidity is AAD, antibiotic-associated diarrhea. AAD is developing in 10% of the patients with the treatment of antimicrobial drugs. Antibiotic-associated diarrhea, this is loose stool by Bristol scale 5 to 7 type, in combination with frequent defecation by patient assessment within 2 or more consecutive days, with or after 8 weeks after the end of antibacterial treatment. What are the reasons of antibiotic-associated diarrhea? Non-infectious, which is direct effect on methylene receptors and stimulation of GI motorics, such drugs like erythromycin, ceftriaxone, then direct damaging effect to the gut microbiota, heterocyclomycin, stimulation of motorics of GI tract. This is clavulanic acid and its metabolites. Infections reasons dysbiosis of gut, diarrhea related to the growth of Clostridium perfringens, Staphylococcus aureus, and specifically Clostridium difficile associated diarrhea. If we compare idiopathic AAD and C. difficile associated AAD, so we can say that diarrhea related to Clostridia most frequently is a culprit in antibiotic clindamycin, cephalosporin, and ampicillin. Diarrhea related to Clostridia can be confirmed by colitis with colonoscopy, by CT, and 50 to 80% of the cases patients have occult blood or leukocytes in feces. Clinical cases, we cardiology department, so we administered patients age 79, so dyspnea with physical exercise, frailty, dizziness, respiratory failure, cough with purulent sputum, and discomfort in chest. So this patient is already hospitalized many times. So currently patients is hospitalized with the exacerbation of cardiovascular pathology and chronic obstructive pulmonary disease. So when we examine in the medical history, we see leukocytosis and increased C-reactive protein. So we administer antibacterial treatment, amoxicillin and clavulanic acid 3 times a day, plus mucolytics. On day 3 of antibacterial treatment, patient demonstrates loose stool, type 7 by Bristol, loose with mucosa, epigastrial pain, and meteorism, blowiness. Leukocytes increased, blood exchange, coprogram, leukocytes 10-15 in the visual field. Immunofluorescent analysis, toxin Clostridium difficile AB negative, and culturing is negative. This condition was considered to be as AAD mild, and we administered metronidazole 503 ID per os and probiotics. On day 3, patient demonstrate normalization of stool, normalization of the clinical condition, then reduction of leukocytosis, GAN C-reactive protein, and in coprogram single leukocytes. Later on, patient is having probiotics and safely discharged home. Infection Clostridium difficile, just few words about that. Back in 1979, so the etiological role of C. difficile was confirmed in pseudomembranous colitis. What are the main factors of pathogenicity of Clostridium? This is toxin A, toxin B, and so-called binary toxin. Toxin A, this is very strong enterotoxin that is causing disorder of barrier function of the gut due to the damaging of the epitheliation and permeability of the fluid into the lumen of the gut. So it forms the complex binary toxin that goes into the cytoplasm and destroys cell functioning due to disorganization of the cytoskeleton and kills the cell. So how Clostridium difficile goes into the organism? Through the spores on the household subject. So these spores go through the gut into the small intestine and then into the colon. There is vegetative forms, but for that we need some background disease. It's either antibacterial treatments or anti-secretory treatments or chemotherapy, cytostatics, and all that facilitates the fact that Clostridium difficile is proliferating. The link of Clostridia difficile with antibiotics. According to the meta-analysis, clindamycin causes 20% of Clostridia difficile, fluoroquinolones 565, cephalosporins, penicillin, macrolides, and other antibacterial treatments. Clostridium difficile is associated with gut damage, can be asymptomatic, absolutely asymptomatic. Diarrhea without colitis is possible, then colitis without pseudomembranous, then pseudomembranous colitis, and fulminant colitis. So there are cases of Clostridium difficile relapse and secondary episodes of symptoms less than 8 weeks after the start of the previous episode or the end of the previous treatment. That is 25%, and further relapses from 45 to 65%. The methods of diagnosis. So currently there are several methods of diagnosis of Clostridium difficile, which is PCR, and this is glutamate dehydrogenase that is used for the identification of the total antigen, then immunoassay for the toxins A and B. This is how the algorithm of CDI is shown here. If the patient has symptoms and there is loose stool, so more than 3 times a day, then we isolate the patient, we identify glutamate dehydrogenase, and if the result is negative, then a Clostridia infection is excluded. If the result is positive, with immunofluorescent analysis to the toxins A and B, and if the result is positive, then we diagnose infection Clostridium difficile, and if it's negative, then it can be false negative or concentration lower than the threshold level, or the patient can be carrier of Clostridium difficile. So such treatment of Clostridium difficile infection, according to the literature data, according to the guidelines recommendations. So if it's not severe course, and the treatment is administered vancomycin, clindamycin, and metronidazole peros within 10 days. If this is severe, then definitely this is mainly vancomycin and sidaxamycin. If it's fulminant, then beside vancomycin peros, then oncomycin per rectum can be used and intravenous metronidazole. So speaking about the relapsing course, then depending on the number of relapses, so the treatment is actually the same, vancomycin and vaxomycin if the previous one was used. So, but here duration would be longer, from 10 to 14 days up to 21 days in case of severe relapsing. In official guidelines to use and to treat antibiotic-associated diarrhea, we see probiotics, and we're actively using them. So probiotics for the treatment of AAD. It is also presented in the Russian and international guidelines. They should be used for at least 3 months for the prevention of C. difficile relapses. after the completion of metronidazole or vancomycin. In our chair, we are working with a probiolog and probiolog forte that has bifida, bacteriolactis, and lactobacillus acidophilus. So probiolog forte can be used QD, and this is high concentration of probiotics. Probiolog and Probiolog Forte are included into the national clinical guidelines by gastroenterology from 2020. Now, speaking about Clostridium infection and fecal transplantation. Well, this is quite controversial data. There is pro and contra fecal transplantation. And the last thing we could find here, because of coronavirus infection and fecal transplantation, we saw if there is a relapsing infection, Clostridium difficile, and this is a high-risk group and no response to pharmacotherapy of vancomycin and standard treatment, then definitely it is recommended to have fecal transplantation. Now, a few words about ursodeoxycholic acid. In the recent years, they spoke a lot about the use of ursodeoxycholic acid because it has inhibiting effect to the growth and proliferation of Clostridium difficile in vitro. And also it has been proven the positive preventive and therapeutical influence of ursodeoxycholic acid to Clostridium infection with modulating effect of this drug to the immune response. Most probably it is related through the phonozoid receptors, nuclear receptors that are actively studied, and TGR5 receptors. On the other hand, ursodeoxycholic acid facilitates modification of gut microbiota, microflora in the patients, and this is also antiseptic for the gut, providing effect to the different elements of microbiocinosis. And we have been working with this drug and ursodeoxycholic acid ultrasound. What is in the focus of discussion, dear colleagues? Prevention of AAG. What can we do in this case? Prevention of AAG is extremely important, and it means we have to use antimicrobial treatments rationally, and this is the basis of our prevention. And I'm sorry for this redundancy. With that, I would like to thank you for your attention. I would like to wish all the best to you and your families. Thank you very much. Thank you very much, Yelena. So this is very interesting presentation, and this is where I want to make an accent. So the whole session here was in the style of practical recommendations, practical ideas, and that is why it is causes such a big interest from our audience. So, distinguished colleagues, we have few minutes for very short Q&A session. Let me ask 2-3 questions. Maybe we manage if experts are answering very briefly. Natalia, my first question to you. So when can we restart dual antiplatelet treatment after GI bleed? For example, if it's a gastric ulcer in patients with acute MI, PCI. Dear Vladimir, well, surely there cannot be standard recommendation. We have to perform gastroscopy, secondary gastroscopy, and dual or triple antiplatelet treatment is contraindicated if there is active bleeding ulcer. So the first condition, we should stop the bleed, and then, according to the Consilium decision, and only then we can restart dual antiplatelet treatment. Well, it's best if this is at least a stage of red scar. Thank you very much. Second question. When PPIs should be administered if needed? Duration of PPIs, if anticoagulants should be used continuously? Well, we can use together with anticoagulants as long as needed. So the duration could be any. And in the study, they have maximum of 15 years of continuous administration in patients with acid-dependent diseases. So it's best to prevent than to treat the bleed. Thank you very much. Final question of our speech session to Yekaterina. She is getting this question. Can we use phosphoglyphins, entirely phospholipids in case of cytolytic syndrome, and if this is the first GP consultation? Thank you very much for your question. No, definitely not. Essential phospholipids are not justified, and you should examine the patients, you should make the diagnosis and treat the disease, but not just the syndrome. So many thanks, dear experts. I think I will provide the unified position. So very interesting, very informative symposium. With that, the agenda for today is completed. Yes, we had very busy and very long day. I remind you, today we considered the issues of hypolipidemic treatment. We again draw attention to the need to reduce residual risks in cardiology patients. Besides, we tackled the issue of particular diagnostic and treatment steps in coagulopathies, in hyperfibrinolysis, also with COVID. That was very, very interesting because all speakers mentioned about that. And we wrapped up with a discussion of gastroenterological diseases in comorbid patients and in patients with cardiological pathology. So, distinguished colleagues, and this is not the end, because tomorrow we are expecting one more very saturated and very interesting day. So tomorrow we see our colleagues from Serbia at 9 a.m. Moscow time. They will consider the issues of diagnosis of diseases of heart and cardiac pain. In fact, that would be really very interesting session. And hopefully the issues of functional diagnosis would be directly continued, the issues of treatment tactics, and the picture of identified changes. And then we continue our discussion, and our symposium will cover the issues of osteoporosis, and that would be the second session where the leading experts will cover complicated clinical and theoretical issues related to that. And we wrap up our symposium tomorrow in the hall St. Petersburg, our segment of the Congress. We will finish tomorrow in St. Petersburg Hall with the topic that seems to be very relevant today, because it deals with the issues of providing emergency care, ambulance, and patients with the pandemic of neuroinfection. And in the last session, we will consider the issues of organizational care, structural medical health care, and also diagnostic and treatment tactics that are currently seen by the experts that are already adopted and quite recommended by the national and international guidelines. So with that, let me finish day 2 and symposium 3 of the online Congress of Eurasian Association of Therapists. Hope seeing you tomorrow. Have a good evening and goodbye.